Okay, guys. So we'll discuss now UPSC CMS paper of medicine. That is again a very important exam in India. So like there are questions of medicine. So these questions are overlap with many preclinical subjects. So here we'll discuss only medicine part and some of the integrated topics, which are like some topics covering pathology, pharmacology, physiology. So all these like clubbed under medicine. So let us see the first question. Urine alkalization as a method for enhancing excretion for poisoning is aimed at achieving. So understand this. So urine alkalization, when we do this for some poisoning, like especially we do this for acidic poison. So this is a method we do for acidic drugs. And here remember the target pH will be, you have to maintain the pH in the range of 7.5 to 8. So basically it is a urinary alkalization, so you have to maintain urinary pH. So answer for this question will be B. Am I clear? So urine pH should be maintained in the range of 7.5 to 8. Coming to next one, exchange transfusion. So understand this. Exchange transfusion we do in a lot of conditions. So again, this is like we can do in a lot of conditions. Out of the given choices, we prefer this in treatment of methemoglobinemia. Is it clear? So remember, there are many conditions. Again, it's given in Harrison, it's given in many forensic textbook, like where we do, there are many other poisoning, there are many indications in medicine where we do exchange transfusion. Coming to third one, like again, psychiatry integrated with medicine, which of the following statements are correct regarding anorexia nervosa? So if you ask me like anorexia nervosa, it's a condition where patient don't want to eat anything. So let us see the first option. Illness is often precipitated by weight loss. Yes, that is a correct statement. So I will say this is rather a true statement. Food avoidance is common. Yes, patient with anorexia nervosa, they try not to eat, right? It is different from bulimia. In bulimia, patient will eat a lot, then they will do self-induced vomiting. So anorexia nervosa, they will not. So they will avoid food. This is the correct statement. Body image is intact. No. Remember, body image is distorted. So this is a wrong statement. And there is no fear of weight gain. There is a definite fear of weight gain. So patient will have fear of weight gain. So this is again a wrong statement. So downy hair, lanugo, you can see some hair development in the skin, the back and the forearm. That is again a correct statement. And patient can also develop amenorrhea. So these are three correct statements I can say. Illness is precipitated by weight loss, food avoidance is common, and downy hairs can be seen. So 1, 2, 4, these are the correct answers in this question. Again, it is like more, I can say there are many multiple choice questions. So you have to know the core concept. That's it to solve these type of questions. So 1, 2, 4 will be the correct answer for this question. Coming to next one. Following are adverse effect of loop acting and thiazide diuretics. Now understand this, whether it is loop diuretic or thiazide diuretic. So diuretic means they will lead to loss of water. So there will be loss of water. That's why there will be hypovolemia, there will be loss of sodium. So there will be hyponatremia, there will be loss of potassium, that I can say hypokalemia, and there will also be loss of H positive ion. So when there is loss of H positive ion, what we call this metabolic alkalosis. So this will result in metabolic alkalosis, not acidosis. So understand this. So question they are asking you, what effect you will see. So remember, hypovolemia you will see, hyponatremia you will see, hypokalemia you will see, metabolic acidosis something that you will not see. You will see, instead of this, you will see metabolic alkalosis. So 2, 3, 4, these are the correct answer. Clear? Okay, moving to next one, which of the following statement is correct regarding peptic ulcer prophylaxis. So understand this. Peptic ulcer prophylaxis, stress ulcers during clinical illness is uncommon. So we call them as like stress ulcers, or we call them Cushing's ulcers. So these are common types of ulcers. Due to raised ICP or due to stress, they can develop in the stomach. So they are not uncommon. This is a wrong statement. They are asking you correct statement. So most of the question which I have time noticing is like they are asking question on correct statement. So they are quite common. They are not uncommon. Then coming to next one, ulcer prophylaxis should be continued once absorption of enteral feed is established. So understand this. A prophylaxis of ulcer you will give sometime, like if a person is admitted in ICU or in emergency and is suffering from some critical illness, then we have to give this prophylaxis even for longer periods. So this is again a wrong statement. PPI are effective at reducing incidence. That is true. That's why we use pantoprazole or any other PPI in every patient to prevent these stress ulcers. PPI when used with antibiotic may decrease the risk of Clostridium difficile infection. So understand, when you use PPI, along with this, if you're using antibiotic, that will increase the risk of I can say pseudomembranous colitis, because antibiotic exposure, that can lead to damage to normal flora, and there will be like infection or infestation by Clostridium difficile, that can lead to pseudomembranous colitis. So this is again a wrong statement. So only correct statement in this is PPI are effective at reducing the incidence of ulcers. Clear? Okay, moving to next one. Following are the feature of post-lumbar puncture headache. So a post-lumbar puncture headache, this is a dull itching occipital headache. It's the correct statement. This is correct. It is worse than walking but improve during the day. No, it is not a correct statement. Recumbency usually improve the headache within minutes. It's again a correct statement. So correct option will be 1 and 3. 1 and 3. Okay, again, this is like a straightforward question again from the horizon table. You can see granulomatous liver injury. So, like you can see, there's a table where there are a lot of, there's a list of drug in horizon that they can cause. We use the term for this is DILI. DILI means drug-induced liver injury. So, understand this. If you ask me about acetaminophen, that is paracetamol, this will cause your centrizonal necrosis. Centrizonal necrosis. And some anti-epileptic, even like allopurinol, and I can say some anti-arrhythmic drugs like diltiazem. These are the drugs which are responsible to cause granulomatous liver injuries. So these three are correct statement. So acetaminophen will cause a centrizonal, or also we call the centrolobular or centrizonal necrosis. So this will damage the central part. So 1, 2, 3, these are the correct statement for drug-induced granulomatous liver injury. Okay, moving to next one. In serological investigation of hepatitis B virus, presence of HBe antigen is an indicator of. Now understand this. HBe antigen, we have discussed this in our class as well. HB surface antigen is the first antigen to occur. Then what we have hepatitis B antigen. It means if this antigen is present, it means the virus is replicating or dividing in your body. So this is a marker for replication or active replication of virus. Acute liver failure, for this generally we don't have a specific marker. Generally we make a diagnosis based on serum ammonia. Chronic infection with hepatitis B, for this we need IgG, anti-HBC antibody. Inactive carrier phase, again not the answer. So answer is for HBe antigen, this is like a marker of active virus replication. Okay, let me write few marker here. Surface antigen, this is the first marker to appear. It is a marker of entry. Then we have hepatitis B envelope antigen. It means this is a marker for replication. Then we have hepatitis B core antigen. It is something that is not detected in laboratory. It is something that is not detected, and we have these are 3 antigens, then we have 3 antibodies. So let me say antibody will be IgM, anti-HBC antibody, and what we have IgG, anti-HBC antibody. Now understand, if you see IgM anti-HBC antibody, this is IgM means it is telling you about like acute infection. So this is the marker for acute infection, and IgG is a marker for chronic infection. Then we have anti-HBe antibody. So understand this. If you see this carefully, HBe antigen was telling you about replication. If you develop antibody against it, means this is end of replication. It is means no longer replicating. No longer replicating. So means virus is now not replicating, and ultimately the last thing what you can get antibodies against surface antigen. We call this anti-HBs antibody. It means this is a marker or a person who have cured from the disease. So that is something which you have to remember. Okay, there was one more question like in the same paper, like what is the marker you will see in window period. So remember, this IgM anti-HB antibody is the only marker that we see. It's the only positive marker in window period. Okay, now coming to the simultaneous infection with hepatitis B virus and hepatitis D virus. So they are telling you about infection at the same time. So whenever there's infection at the same time, what we call this as co-infection. Co-infection. So whenever there is co-infection with hepatitis B and D, B plus D together, we call this co-infection. B first followed by D, that's called superinfection. Followed by full recovery, means patient is fully recovered. So patient is fully recovered is associated with appearance of, so understand this. So whenever there is full recovery, so by logic you should understand this, whenever there's recovery, it means antibody titer should be more. So this low titers I am ruling out. Simple. Is it clear? And they are telling you like there is full recovery. So what will be the antibody? So these two are ruled out, low titers. So there will be high titers of anti-HDV and that will be of IgM type because it's the infection at the same time, acute condition. Is it clear? So understand this, IgG will be chronic. So that is again not the answer. So remember there will be high titer of antibody because that is telling you about recovery, and IgM type, it means it's suggestive of co-infection. Okay, coming to next, which is the following statement is true regarding jaundice. So understand, first is presence of scleral icterus indicate a serum bilirubin level of at least 3. That is true. It's the correct statement. Understand, whenever you see icterus in the sclera, it means the bilirubin levels are more than 3. If the examiner suspects scleral icterus, second site to examine is underneath the tongue. That is again a true statement. So first we see the skin of the patient, there will be yellowness in the skin. Then we can see the nail bed, we can see the sclera, and it's followed by the tongue. So that is again a true statement, correct statement. In long-standing jaundice, skin may become green due to reduction of bilirubin to biliverdin. That's also a correct statement. A person who's having jaundice, I can say for more than 20 days, then there will be conversion of bilirubin to biliverdin. Sclera have a particular affinity for bilirubin due to its high elastin content. That is again a true statement. So in this question, you can see all the 4 options are correct. So 1, 2, 3, 4, all these options are correct. So this will be the answer. 1, 2, 3, 4, all options are correct. Okay, coming to next one. Carotenoderma. Carotenoderma, understand this, due to ingestion of excess amount of carotene containing fruits and vegetables can be distinguished from jaundice by sparing of which of the following. So again, understand this. If you see patients having carotenoderma and jaundice, both will have yellow skin. So there will be yellow skin in both, that you can notice. So there will be yellow skin in both. Then how we can differentiate? Understand this. This can be differentiated by sparing of sclera. So remember, it's very, very important point. Again, straight away line to line question, this came from Harrison. So you can easily differentiate this by sparing at the sclera. Okay, this was something, a new question. Again, we don't use this test nowadays. So this was a question like Maris Stamlet test is used. This is used like in a patient who is having recurrent UTI. It is used especially in male patient because males, they do have prostatic secretion. So that is used for recurrent UTI. Nowadays, we don't use this, but again, a question came in exam, so you should know this is a test that we use for recurrent UTI in a male patient. Next is, with the following drug is associated with calciphylaxis in chronic kidney disease patients. So understand this. In CKD, we have discussed this topic. CKD patient, they can develop inflammation of the subcutaneous tissue that can lead to necrosis at a particular site. We call this calciphylaxis, although it is not commonly seen. Even like again a photograph, it's given in the Harrison, that is written like it is calciphylaxis due to certain drugs like warfarin. So it was again a line to line question from Harrison. It is due to use of anticoagulants like warfarin. So calciphylaxis, remember, this was something new which came for the first time in exam, and they are testing this question. They can ask you some more things about this, about calciphylaxis. So remember, warfarin is the common drug which can trigger calciphylaxis. Okay, coming to again, this is a question straight away from our notes. RBC cast, where you see WBC cast. So let me tell you, like RBC cast, generally we see them in a patient with glomerulonephritis. But you can also see this RBC cast in a patient with vasculitis, in a patient with malignant hypertension. So this is a true statement. You can also see this in malignant hypertension. That's given in the answer. WBC cast, remember WBC cast generally you will see in a patient with pyelonephritis. Again, that is given. Pigmented cast is not seen in vasculitis. And granular cast, remember the granular cast, it is seen in a patient with I can say sometime ATN, acute tubular necrosis, or tubulointerstitial disease. Again, it is not seen in myoglobinuria. So these two are wrong statement. So only RBC cast and WBC cast they have mentioned, that is correct. So remember, they are asking like how many pairs are correctly matched. So remember, only 2 pairs are correctly matched, 2 are wrong. Simple. Which of the following is primary underlying mechanism of hemolysis in PNH? So understand what is happening in PNH. So we have, suppose this is RBCs. These RBCs are good source of nutrients. So what they have, I can say, they hire some bodyguard. These 2 bodyguard are CD55 and CD59. We call them as DAF and middle. DAF and middle. So understand this, RBCs, they are in the blood. In the blood, what else we have? We have alcohol, we have toxins, we have drugs, we have many bad things. And who is protect? This will stimulate. This will stimulate MAC. MAC is C5B29. So normal people understand this. They do not get any damage because this DAF and MIL, they are acting like bodyguard. So what happened in PNH? There is a big A gene mutation, and this gene mutation will result in a deficiency of DAF and MIL. So when there's DAF and MIL deficiency, these toxins or MAC, they can easily damage the RBC. So remember, this C5B29 is complement protein. So it is a defect, that is complement mediated destruction of CD59 in the RBCs. So understand? So PNH is not due to ABO incompatibility. ABO incompatibility, what it will give you? It will give you hydrops vitalis. A red cell fragmentation we see in a patient with MAHA. And this will produce helmet cells, right? Exotoxin produced by Clostridium perfringens, again, this is not leading to PNH. So PNH is basically it's the defect of PEGA gene that is resulting in C5B29, that is complement mediated destruction of RBCs because of mutation of PEGA gene and absence of DAF and MIL. So this is the correct answer. And DAF and MIL, they have CD marker, CD55 and CD59. That is why we make a diagnosis for this condition with flow cytometry. And if you ask me, like drug that we use in this condition is eculizumab. So investigation of choice will be flow cytometry. Like some of you are thinking of HAM test. HAM test is not considered a good test nowadays. And how we treat this, we give eculizumab. Eculizumab. Okay, moving to next one. Following is clonal hematopoietic stem cell disorder. Okay, so before this question, let me tell you, like there were 3 topics which were tested heavily in exam. So which I noticed, first is they asked a lot of question on RBC disorder. Means hematology was loaded in exam. The second thing was there was a lot of question in hepatitis. Then third thing is important, like there was a lot of question on thyroid. So these are the 3 topics which were tested heavily in exam. So you can see in the discussion. So see, clonal hematopoietic stem cell disorder, they are asking you which is clonal hematopoietic stem cell disorder, in which phenotypically normal red blood cells, means RBCs are normal, granulocytes are normal, platelets, they will accumulate in absence of recognizable physiological stimulus. So understand this, mastocytosis is defect of mast cells. So that's again not the answer. So here they're asking you about RBCs, WBCs and platelets. They all are accumulating, means all 3. In essential thrombocytosis, you will see only platelets are accumulating. In myelofibrosis, there will be fibrosis in the bone marrow that will lead to destruction of hematopoietic stem cells. So polycythemia vera, that is due to JAK2 kinase mutation. It is a condition where you will see RBC, WBC, platelets, all cell lines will increase. All these 3 will accumulate. So answer will be B. Coming to next one, which of the following insulin has a cloudy preparation and requires resuspension prior to injection? Means understand this is they're asking you in simple language which type of insulin you have to shake well before use. So shake it till you make it, or you have to shake it. So that is like if you see in practice we use this a lot. Lente is a type of insulin preparation that is having a cloudy preparation and we have to shake it gently, only then we can use it. So glargine, detamide, degludec, these are clear suspension. These are not I can say cloudy preparation, these are clear. So lente is the insulin that is cloudy in nature. Okay, again the easy one. Which of the following are typically physical finding in pericardial effusion? So like pericardial effusion, when it's massive, we use the term cardiac tamponade. So that whenever there is cardiac tamponade, the patient will have feature of raised JVP. That is the true. So they're asking you which are the features. So this is the correct statement. Raised JVP, hypotension and muffled heart sound. You know that these 3 things, these are like we call as backstride. So raised JVP is seen, hypotension is seen. And whenever there is effusion, that can lead to compromise in the kidney. The patient can develop oliguria also. Water hammer pulse is not seen. Water hammer pulse is not seen in massive pericardial effusion. Instead, what we see, we get pulsus paradoxus. That's very, very important. Water hammer pulse is seen in AR. This is something that we see in AR. We also call this water hammer or Corrigan pulse. So correct answer for this question will be 1, 2 and 3. So answer will be 1, 2 and 3. Okay, moving to next one. Following true or true about PR interval. So see, let us see this question. So PR interval denote atrial depolarization. It's correct or not? No. It's actually the P wave. It is P wave that is representing atrial depolarization, and QRS will represent ventricular depolarization. So normal duration is 0.1 to 2.2 second. That is true. This is the correct statement. We call this like a 3 to 5 small box, or 0.1 to 2.2. Prolongation is PR interval. So if you see, if I make an ECG in front of you, this will be your first wave P wave, then this is followed by QRS, then we have T. So this interval, that is starting of P to this R, we call this PR interval, right? Now understand, when we have PR interval, this PR interval will prolong. It means this will prolong in a patient who is having bradycardia, or I can say AV block. So this represent AV nodal delay. So in first degree, in second degree, third degree AV block, what you'll always see, you will see there will be prolongation of PR interval. So that is again a correct statement. A short PR is seen in WPW syndrome. That is again true. In the initial portion of QRS, you will see like there will be a slurry upstroke like this QRS. This slurry upstroke in the initial portion of QRS, what we call this as delta wave. This is called delta wave. So that is again, you will see short PR in WPW, that is due to aberrant conduction. So this is also a correct statement. So correct answer for this question will be 2, 3 and 4. 2, 3 and 4. Okay, moving to next, the following again a straightforward pharmacology type of question. You can see, following the drug of choice for treatment of schistosomiasis. So for schistosomiasis, what we can use praziquantel. Moving to next one. Again, I can say this is the easiest question which came in exam. Following opportunistic infection, opportunistic mycosis is characterized by rapid development of severe tissue necrosis. So this is the first hint in the MCQ, tissue necrosis. And this emerged in India as a specific complication with COVID-19. So you all know, like first hint is COVID-19, and second hint is severe tissue necrosis that we see in a patient with mucormycosis. And the third thing they are giving, it's a systemic mycosis. Right? So it is a case of mucormycosis. Okay, moving to next one. Following fungal infection is caused by dermal inoculation of the fungal agent, usually from a thorn. What we call this rose Gardner disease. When you are pricking a rose, that is due to which condition? Just come on, sporotrichosis, right? Very good. Again, a microbiology overlap with medicine question. Now this is following statement are true regarding coccidiomycosis. So let us see. It is primary systemic mycosis caused by a dimorphic fungi. Coxodus immitis and Coxodus posadacea, that is a correct statement. It's a dimorphic fungi. Primary pulmonary coccidiomycosis present with cough, fever, chest pain and arthritis. So generally, like, it's a pulmonary, so you will have pulmonary manifestation like cough, fever, chest pain. These are pulmonary manifestations. That's again a true statement. Progressive pulmonary coccidiomycosis present with constitutional symptoms. Like when it is progressive, you will see fever, weight loss, anorexia, and there can be feature of lobar pneumonia. That's again a true statement. Coxodioides meningitis is mild disease. This is something which is hitting my brain. Always remember, fungal meningitis is never a mild condition. Fungal meningitis are always dangerous. It's never a mild condition. It not warranting any treatment. It need aggressive management. So this is a wrong statement. So correct option. So they're asking you correct statement. So correct statement will be 1, 2 and 3. Remember, fungal meningitis, they are always dangerous and they require aggressive treatment. Okay, then they're asking you a question of snake bite, following statement with regard to elapid snake bites. Understand? Regardless of the anatomical site of bite, walking of the victim should be discouraged. That is true. It's a true statement. Pressure embolization should be used wherever possible. That's again a correct statement. Ptosis can present. Yes. Ptosis can also present. So remember, all these three options 1, 2 and 3, these are correct. All these three are correct. Okay, moving to next one. Again, this is like a basically like basic science physiology based question. Following hormone responsible for gallbladder contraction and release of bile into duodenum. So that is your we call the CCK-PZ, cholecystokinin. CCK, that is cholecystokinin is the hormone that is responsible for gallbladder contraction and release of bile. Moving to next one. This is again like this was a good question. Like we have this type of case in oncology department. So you can see they're asking question related to radiation enteritis. So radiation enteritis at proctocolitis. Understand? So whenever a person is developing this kind of condition, then remember, diarrhea is a common finding. So diarrhea, how you will treat? You can treat this with codeine, or we can use loperamide. That is a correct statement. Then coming to next option, surgery is the treatment of choice and involves resection of tissue in injured intestine. Again, it is radiation induced, so we try to do the minimal surgery. Surgery is not the treatment of choice. We try to avoid surgery as much as possible. It's the wrong statement. Sucral enemas and hyperbaric oxygen are effective treatment. So sucral enema we use. That's the truth. We use it very commonly. So this is actually used, sucral enema. Hyperbaric oxygen is not available in many centers, but still we use. Wherever it is available, we use this. So these is also a correct statement. Small bowel strictures and rectovaginal fistula may develop as a chronic complication. Yes. So there can be stricture formation, there can be fistula formation. That is a common thing which we can see. So 1, 3 and 4, these are correct statement. Moving to next one. Which of the following drugs are useful in treatment of Listeria monocytogenes? So like a drug of choice for Listeria infection is ampicillin. Drug of choice will be ampicillin. And sometime remember, if it is like a patient having a high TLC count, it is not easily controlled with ampicillin, then we add gentamicin. So generally what happens in practice is whenever we see a patient with meningitis, we start empirical antibiotic. That empirical antibiotic of choice is ceftriaxone. But whenever the culture report arrives, then we see, if we see Listeria infection, then we should have to stop ceftriaxone because there is no role of adding ceftriaxone. So ampicillin gentamicin combination is generally that we use. And third thing which we can add is something called sulfamethoxazole. Remember, ceftriaxone will not have a role in Listeria monocytogenes. So correct answer for this question will be 2, 3 and 4. These 3 are used. Okay, moving to next one. Following is a cause of relative erythrocytosis. So we have 2 types of erythrocytosis, that could be absolute and relative. So remember, high altitude cardiorespiratory disease, high affinity hemoglobin, these are the causes of absolute erythrocytosis. Absolute erythrocytosis. And remember, diuretic is the only cause mentioned here, that is the cause of relative erythrocytosis. Okay, coming to UTI. So urine is an excellent culture medium for bacteria. So whenever you see urine, there is a pungent smell. If urine is in the air, then you can see it will attract many pathogens. So that is, again, it's an excellent culture medium. It's a correct statement. Atrophic urethritis is in postmenopausal woman is a risk factor. So atrophic urethritis is very common in postmenopausal women. That's again a correct statement. Antibiotics are recommended in all cases of asymptomatic bacteria. Again, this is very, very interesting thing. Understand this. Many of us, sometimes you are going for a routine routine microscopy checkup, and there are some bacteria are present, but we don't have symptoms. That's called asymptomatic bacteria. So in that case, what you will see, no doctor will give you any medication, because remember, it's like a self-limiting condition. There are some bacteria which are normal commensal, and there are some bacteria which can be cured with body's immunity. So remember, all this asymptomatic bacteria is a condition which do not require treatment. So antibiotics generally we don't recommend. And certain strain of E. coli have a particular propensity to invade urinary tract. That's true. So remember, UTI, the most common cause, if you ask me, first most common, second most common, third most common, the most common cause of UTI, it is E. coli. So that's why we use drugs like fluoroquinolones, and we can use drugs like nitrofurantoin. So these are the drugs that we use in UTI. So remember, the most common cause is E. coli, and certain strains are very specific. So correct answer will be 1, 2 and 4. 1, 2 and 4. D. So I can tell you, like, most of the question what they're asking a question related to correct answers. Okay, next is about scorpion sting. So scorpion sting, remember, this is something which is very common in villages. So scorpion inject venom from a stinger on their tail. That is true. Most stings are painful but relatively harmless. That is also a true statement. Like a patient will have severe pain, so we can give I can say some painkiller to patient. But remember, they are not that they are not that harmful, so they are harmless. That's again a correct statement. Anticholinergic can be used if antivenom available. So treatment of choice will be like scorpion antivenom. If that's available, along with this we can use anticholinergic. That's also a true statement. But remember, treatment of choice will be anti-scorpion venom. So 1, 2, 3, 1, 2, 3. These all are correct statement. Okay, moving to like a social, I can say preventive medicine overlap with medicine. We have question on Kaisanur forest disease. It's commonly seen in northeastern state of India. No, this is a condition that is seen in Karnataka, not in northeastern state. Monkey act as reservoir. True. Transmission happen through tick bite. That's also true. It is basically a hard tick that causes the infection. inactivated vaccine is available for its prevention. So this is something like vaccine is available, but again it is not routinely used. But remember, it's available. So 2, 3, 4, these are correct statements. Okay, coming to next question on brucellosis. So understand, fever may develop into an undulating pattern that persists for weeks. In fact, in brucella, what we call this undulant fever is another name. So that's the correct statement. Associated musculoskeletal symptoms are feature of disease. That is, like in brucellosis, patient will have many arthralgia, body ache, muscle ache. So these are common symptoms. Brucella behave as facultative intracellular pattern. That's also a correct statement. So 1, 2, 3. All these are correct in this question. Now you are thinking like these are questions which are not coming directly from the medicine, because remember, these are those questions to solve this question you should have at least a good knowledge of preclinical subject as well. So if you are reading your notes thoroughly, like anatomy, physiology, biochemistry, microbiology, PSM, pathology, pharmacology, everything is important, because they are telling you like it's a paper based only on medicine, surgery, gyne, pediatrics, but it's not actually true. They are also asking you question from different areas. Okay, 60-year-old diabetic female present with acute MI. ECG changes include ST elevation greater than 1 mm in lead AVR. So straight away they are giving you question on lead AVR, so you can easily pick the answer. It's like left main or proximal LAD obstruction. Following anti-diabetic drug is recommended for weight loss in obese patients. To understand, for weight loss, we have 2 drugs which we can recommend in diabetes patient. One is liraglutide, which is FDA and WHO approved. Second is metformin, which is not yet approved. So remember, liraglutide and metformin, these are 2 drugs that we can use. If you ask me about glimepiride, this is sulfonylurease, this will cause weight gain. Sitagliptin, like it is DPP-4 inhibitor, which is considered a weight neutral drug, and insulin is anabolic hormone that will increase the weight. Moving to true statement regarding inflammatory bowel disease. So remember, first option they are giving you like ulcerative colitis involve terminal ileum and rarely cause proctitis. What do you think, is it correct or not? Ulcerative colitis is the condition which involve colon and rectum. And remember, most common is not colon, most common is rectum. So it rarely, no, it's commonly cause proctitis. Proctitis means inflammation of rectum. This is a wrong statement. Cobblestone appearance of bowel is seen in Crohn's disease. So this is actually true. Cobblestone we see in Crohn's disease. Escape lesions are characteristic feature of ulcerative colitis. No. Escape lesions are seen in Crohn's disease. Wrong. Ulcerative colitis is more common in smoker than non-smoker. Ulcerative colitis is, in fact, I can say smoking is protective. It is not common in smokers. Smoking is protective. So only correct statement in this option will be only second option, that is cobblestone appearance is seen in Crohn's disease. Okay, moving to next question that is related to obesity. So adiponectin levels are reduced in obesity. That is a true statement. This is a correct statement. Then we have a drug like orlistat. It is a lipase inhibitor. That is a reversible lipase inhibitor. And we use this. In fact, like many books, they write it's a drug of choice for obesity. So it is actually the drug that we use. Liraglutide used for type 2 diabetes management can cause weight gain. No. Just now I told you in the previous question, liraglutide is something that is used for obesity. It will not cause weight gain. It will cause weight loss. And not recommended in obesity. No, it is recommended. It is, I told you, it is only FDA and WHO approved drug. So this is a wrong statement. Bariatric surgery is recommended in obese patient with BMI more than 30. So understand this. Bariatric surgery is a treatment in obesity. We recommend this to obese patient, but not in patient with BMI is more than 30. We recommend this when BMI is more than 40. Or we can recommend this in BMI is more than 35 with some cardio or respiratory comorbidities. Is clear? So this is again a wrong statement. So bariatric surgery is recommended, that's true, but remember that BMI range is wrong. So this is the wrong statement. So only correct statement here. What we have only 2 statements, 1 and 2. 1 and 2. Clear? Okay, moving to next thing. Following drugs therapy are effective in preventing uric acid nephropathy in patients receiving chemotherapy. So understand, whenever you give chemotherapy to patients, so there is a chance of development of urate stone that can lead to urate nephropathy. So how we can prevent this? So probenecid is a drug that we can use that's having uricosuric action. So this we can use. Probenecid is uricosuric drug. Forced saline diuresis also we can use. Rasburicase, like it's a drug of recombinant DNA technology. This is we rarely use. Basically, it's used to treat chemotherapy induced tumor lysis syndrome that can lead to hyperuricemia and gout. But again, we can also use, yes, rasburicase and many times in refractive urate nephropathy and in refractory gout. So rasburicase also we can use. Astazolamide, remember astazolamide we don't use. So correct options are here 1, 2 and 3. 1, 2 and 3. Okay, primacoin destroy hypnozoites. So primacoin, they are destroying hypnozoite of plasmodium for radical cure in which of the following? So primacoin, they will straight away destroy the hypnozoites there. The hypnozoite, they will straight away destroy the hypnozoites in the liver, inside the liver. That is what we call this radical cure. Okay, then we have a question, HIV associated neurocognitive disorder, we call this HAND. Again, a straightforward question from Harrison. This was given in 20th edition as well as 21st edition. You can see HAND include which of the following. So like people with HIV, they can develop asymptomatic neurocognitive disorder, then sometimes there will be minor problem, and then sometimes patient can develop dementia. So this is like a sequence that we see. So all these three, 1, 2, 3, these are correct. Okay, then we have a following statement regarding cysticercosis. So understand, cysticercosis, it may present as personality change. So understand this, cysticercosis in later stage, remember, not in early stage. In early stage, this will present only with seizures. Seizures, sometimes with headaches. So most common finding will be seizures. But in late stage, it can lead to personality change. That's the correct statement. Subcutaneous nodule may be excited for histology. Yes, we can use the subcutaneous nodule to take biopsy or for histology examination. That's correct. Cerebral signs commonly do not occur until the larva die 5 to 20 years later. So generally that is true. That's true statement. Cerebral signs do not appear until larva die. And praziquantel can be given for 10 days. Yes, generally we give praziquantel for 10 days. Even sometimes we can give this for more. So that all these options are correct. So correct answer will be 1, 2, 3 and 4. 1, 2, 3 and 4. Okay guys, coming to next question. Consider the following statement with regarding to strongyloids. So understand this, it parasites the mucosa of upper part of small intestine. So again, this is a true statement. Larva occurrence is fast moving transient rash seen across abdomen and buttocks. So this is again also a correct statement. You can see a classical rash in the abdomen, in the thighs, in the buttocks area. Ivermectin is not an effective treatment. In fact, I can say ivermectin is the drug that we use to treat this condition. So this is the wrong statement. It is the drug that we use. Then systemic strongyloidiasis is seen in immune competent state. Now understand, whenever you read this line, remember always dangerous parasitic or helminthic or I can say protozoal or fungal infection, they tend to occur more in immunocompromised patient than in immunocompetent. So remember, it is not seen in immunocompetent. This is a wrong statement. It is seen in immunocompromised patients. So there are only two correct statements here. That is option number 1 and option number 2. So answer for this question will be 1 and 2. Okay, one more question related to infectious disease. So we have consider following statement with regards to cutaneous larva migrants. So it is one of the commonest linear lesions seen in travelers. So that is true. You can see linear lesions are seen. It's very common in travelers. So this is a true statement. It may be associated with recent visit to beach. So dog, cat feces, they are in the beach. So that's why it's a common thing. Whenever you are going to beach, you are sleeping or lying in the sand of the beach. So from there you can get this disease. So that is again a true statement. It is non-protic. No, absolutely wrong statement. It's a heavily protic in nature. So patient will have huge itching. Track move across the skin at the rate of 2 to 3 centimeter per day. This is also a correct statement. So these three options are correct. 1, 2 and 4. 1, 2 and 4. These three are correct options. Clear? Third is wrong. It is protic in nature, remember. Following statement with regard to giardiasis. Understand this. So giardiasis, it's caused by Giardia lamblia. So stool should be examined for cyst at 2 to 3 days interval for its diagnosis. This is correct statement. Colonoscopic aspirate give the highest diagnostic yield. No, it's mainly a defect of your upper intestine. So your duodenum will be affected more, not colon. So basically endoscopy you can do, but not colonoscopy. It's not a high yield diagnostic yield, or this colonoscopy aspirate will not give you any significant finding. Infection usually occur by ingesting contaminated water. That's a true statement. And Giardia has a flagellated trophozoid form. That is also a true statement. So these three, again, you cannot solve this question without having knowledge of microbiology. So it's very, very important to understand the core of medicine. First, you should have a strong basic of preclinical and paraclinical subject. So 1, 3 and 4, these are correct statement. So option number C will be the right answer. Okay, now again, we have next question related to type 2 necrotizing fasciitis. So if I use this term necrotizing fasciitis, so we can divide this into 3 types. So we can have type 1, type 2 and type 3. Type 1, type 2 and type 3. So understand, if you ask me like type 1, this type 1 is caused by, so question they are asking about type 2. So remember, this type 1 is not caused by any single microbe. It is generally like a multi-microbial inflammation. We call this a polymicrobial inflammation. So you can call this as a mixture of many microbes. We call this polymicrobial. This type 2 is caused by Streptococcus pyogenes. Streptococcus pyogenes also called as group A. Group B is agalactic. And this type 3 is nothing, it is due to your Clostridium, that is leading to gas gangrene. So understand this. So out of this, remember, type 1 is polymer. They are asking question of type 2. So straightforward, this is due to Streptococcus pyogenes, also called as group A Streptococcus. That's very, very important. Again, a microbiology or infectious disease question that they can ask you in exam. So now coming to pharmacology, which are the following insulin preparation has a longest effective duration of action. So understand that they're asking simple about a long-acting insulin. So we can have short-acting insulin. We can have intermediate-acting insulin. And we can have long-acting insulin. So remember all the insulin which are having alphabet S in their name. That is short acting, means Lispro, Aspart, Glulysin. So if you notice carefully, you can see the word S, Glulysin, Aspart, Lispro. Intermediate, what we have NPH. NPH is a neutral protamine hagedron, and regular insulin. And now coming to long acting. So understand what long we have. We have long distance relationship, long distance, D4 distance, D4 detemer, D4 digludac, D4 distance. And long can be synonymously called as large. So I can say large, and I am writing it like this, large or glargine. So you can see Large, E is little for largen. So they are asking you like question is not a short or intermediate. They are asking which is the longest. So understand this. Every insulin is having a particular T half. For example, if you ask me about glargine, so you can say like the effect of the insulin will be lasting for around 24 hours. But there is one insulin that is not routinely used, that is called digludac. But remember, this duration of action of the insulin can be lasting for up to 2 days, means up to for 48 hours. So answer will be digludac. Is it clear? So remember, detemer, it's around like 20 to 24 hours, glargine is 24 hours, and digludac is 48 hours. So that's something which you have to remember. Functioning pituitary adenoma most commonly arise. So remember, I told you like most common tumor of pituitary, these are non-functioning microadenoma. But if they're asking functional means it is releasing some hormone. So mostly what they release prolactin. So functioning means they are releasing hormone. So that hormone is generally prolactin. And that tumor is called prolactinoma. So you should know like prolactinoma is originating from which type of cells. So like somatotrope, they will release GH, growth hormone. Lactotrope, we also call them lactotrope, or they can use the word mammotrope. These are the ones which will release prolactin. Corticotrope will release ACTH, and thyrotrope will release TSH. So answer for this question will be, it is lactotropic adenoma. Prolactinoma is also called as lactotropic or mammotropic adenoma. Coming to next one, low serum thyroglobulin levels are seen in. Now try to understand this. So whenever there is a condition where you'll see like a hyperthyroid state, then thyroglobulin level will be also high. So if you see grave disease and toxic multinodular goiter, these are two conditions where thyroid hormone levels are high, so thyroglobulin level will be high. When I talk about subacute thyroiditis, so that is an inflammation of thyroid gland. Here also you can see thyroglobulin levels can be high. But whenever there is, I can say, a hyperthyroidism due to some exogenous consumption, for example, I can say many Ayurvedic medication, like especially I can say weight loss supplement, and sometime I can say like animal meat. For example, whenever you are eating non-veg food, so suppose bigger the animal, bigger will be their thyroid gland. For example, cattle or beef, so they have bigger thyroid gland. So accidentally you are also eating their thyroid gland. So there can be sometime like we are not knowing, but we consume a lot of thyroid, or I can say iodine in our diet. So that is called thyrotoxicosis factitia. And here you will see like this is the source of this thyroid will be coming from the outside. So remember, serum thyroglobulin level will be low. So answer for this question will be A. Thyrotoxicosis factitia, that is due to either Ayurvedic medication or I can say due to animal food. So we call them like accidental iodine or thyroid consumption. Okay, coming to next question. A 45-year-old male present with polyuria. So polyuria, polydipsia, polyphagia. So polyuria, polydipsia, these are two classical symptoms. Polyphagia is not classical, but again considered symptom for the last 3 months. His plasma fasting plasma glucose is 106. You know, to make a diagnosis of diabetes, fasting blood sugar should be more than 126. But here in the question it is written 106. But random is given 220. So just try to understand this. To make a diagnosis of diabetes, what we need? To make a diagnosis of diabetes, what we need fasting blood sugar should be more than 126. 2 hour meals, 2 hour post meal means postprandial blood sugar should be more than 200, and HbA1c should be more than 6.5%. These two are values in milligram per deciliter. HbA1c is more than 6.5. And remember, fourth thing that we can make a diagnosis, like if any person is having random blood sugar, random although it's not a good test, but random more than 200 plus symptom. If random plus symptoms are also there, then also we make a diagnosis of diabetes. So here you can clearly see, if you see in this question, polyuria, polydipsia, polyphagia, random plus symptoms, so it's a definite diagnosis of diabetes. It is not impaired glucose tolerance, right? So it's a definite diagnosis of diabetes. He does not have diabetes, wrong statement. Diagnosis of diabetes is indeterminate as HbA1c value is not provided, no, it's wrong statement. So this is, remember, how we make a diagnosis, either these three values or random plus symptom. So very important thing. Okay, coming to next, they are asking true statement regarding use of SGLT2 inhibitor. So SGLT2 inhibitor, like what Harrison says, like these are the future drugs. So right now also we use this a lot in India. Even they are also approved in treatment of, in prevention of heart failure. So like we know we have drugs like anagliflozin, empagliflozin, dapagliflozin. These are drugs that we commonly use. So they are used in type 1 and type 2 diabetes and pancreatic forms of diabetes, no. So they are not used in type 1. This is a wrong statement. Neither they are used in pancreatogenic. They are used in type 2 and they are used in heart failure, even in non-diabetic patient, remember. They cause increase in blood pressure by 3 to 6 mmHg. Now see, these are the drugs which are like having a diuretic like of action. Is it clear? So they are basically acting on a sodium glucose transport. So remember, these are the drugs, they will not increase the blood pressure. They will rather decrease the blood pressure. So they will not increase the blood pressure, hence avoided, no. So you can give this. Even I told you, like we give this in we give this in heart failure patient. So this again a wrong statement. Their glucose lowering effect is dependent on insulin secretion and insulin sensitivity, no. This is the beauty of this drug, and like what Harrison says, like these are the future drug, and near future they will become the drug of choice. Right now, like we start the patient with metformin because of its like easy availability and it's very cheap. So remember, there's if I say SGLT2 inhibitor, they have advantage, like they can prevent nephropathy, they can prevent heart failure. These are the drugs which are having a good glycemic control. They can lead to faster reduction of HbA1c, So basically, like diabetes patient, how they die either because of heart failure or kidney failure, and this is the only class of drug which have benefit in both these two things. So actually, it prevent mortality. That's why like Harrison write this as future drug. So their blood glucose lowering effect is not dependent on insulin. One problem with them, like it can cause UTI, and one more thing, like since you are giving the drug, so glucose will be controlled, but patient can develop euglycemic diabetic. Actually, what we use the term euglycemic ketoacidosis. So euglycemic ketoacidosis is a common side effect that we see with this type of drug. Very, very important. Okay, now see next question. A 50-year-old lady who is known in case of rheumatoid arthritis, present with abdominal obesity, moon phases, stria, hypertension. So diagnosis for this condition I already know now. That's Cushing syndrome. Right. Overnight suppression test dexamethasone shown serum cortisol is greater. This is something which is interesting. So it may be a mistake in exam, or if it is given, then this is like given to confuse you. So it's actually, I can say, a good question. So what generally when we see this case, like most of you have marked the answer like it's the Cushing syndrome, that is due to exogenous glucocorticoid use, because rheumatoid arthritis patient, they are taking steroid. Many of these patients, they are taking steroid. Now see, serum ACTH is less than 1. Adrenal imaging and brain CT MRI is normal. Likely diagnosis is. So first thing, let us see this question. If you see Cushing disease means that's a problem in the pituitary. Disease term we use for a pituitary ACTH secreting adenoma. So here in this condition you will see ACTH will be more. Since in this question ACTH is given less, so this option is ruled out. Ectopic ACTH secreting tumor, like for example, it can be carcinoid, or it could be small cell carcinoma of lung. Here also again, ectopic means here also ACTH will be more. So that's ruled out. Exogenous can be the answer, but remember, whenever you are taking exogenous glucocorticoid, then because of this, remember, serum cortisol will be reduced. But here, what is given in the question, this is the hint that cortisol is greater. It is not reduced, it is more. So now, since I have ruled out 3 options, so now you are saying, sir, CT MRI is normal. It could be a small tumor in the adrenal gland which is not detected in CT and MRI sometimes. So that my diagnosis for this case will be a small adrenal adenoma which is not detected in MRI. So answer will be D. But if the question is having a mistake here, if cortisol is given small or given less than 50, then answer will become exogenous glucocorticoid use. Okay, coming to next, 27-year-old lady underwent thyroidectomy. So lady underwent thyroidectomy for thyroid carcinoma. Post-operative, she started developing muscle cramp, perioral, peripheral paresthesia, carpopedal spasm. So indirectly, they are telling you like patient is having symptom of hypocalcemia. That is true. Why hypocalcemia? Sometimes whenever we do thyroid surgery, accidentally we remove parathyroid gland as well. So it's actually diagnosis will be, it's a case of hypoparathyroidism. That hypoparathyroidism is leading to hypocalcemia. Is clear? And because of this hypocalcemia, you can see patients having features like these features. I can say muscle cramp, you can see in hypocalcemia. You can notice perioral, peripheral paresthesia and carpopedal spasm. So we have like a Trousseau sign. We call this Trousseau sign. And there's one more sign, that is what we call, when we tap here, you can see twitching. We call this Chvostek sign. So what you will do, like it's a case of hypocalcemia. So next thing is what you should measure serum calcium. That's simple. NCV is done? No. No need of NCV. Electromyography? No. Measure serum ionized calcium and administer IV calcium gluconate. Simple. Measurement of bicarbonate? No. So it is a simple question. They are asking about hypocalcemia. Okay, so again, this was also a hot topic. They have asked you a lot of questions on anti-diabetic drug. Following anti-diabetic drug may cause weight gain. So let's see the question one by one. You can see glimepiride. Glimepiride is sulfonylureas, right? So sulfonylureas, I can say the sulfonylureas, they are known to cause weight gain. So this is correct statement. Side effect of sulfonylureas is it will cause weight gain. Coming to next is pioglitazone. Pioglitazone is a drug that include in thiazolidinedione group. And this drug, what they will cause sodium and water retention. So when they will cause sodium and water retention, again because of more water weight is more, so that they will also cause weight gain. Coming to NPH insulin, remember all the types of insulin, whether it is NPH, regular, short-acting, long-acting, lente, hemi-lente, ultra-lente, any type of insulin, these are having anabolic action. So what they will cause? They will also cause weight gain. Sitagliptin is a DPP-4 inhibitor. So this is a weight neutral drug. This will not cause increase or decrease in weight. So this is a DPP-4 inhibitor. So that is not causing weight gain. So by this I can mark the answer 1, 2, 3 is correct answer in this question. Simple. Okay, moving to the next, the easy one. Duffy antigen serves as a receptor for which of the following protozoal parasites? So that's simple, very easy one. So Duffy antigen system, that is serving as a receptor for Plasmodium vivax. So if you have the Duffy antigen, you are protective against Plasmodium vivax. Okay, then they're asking question on cryoprecipitate. So first thing you should know, like what is cryoprecipitate? So we have whole blood. This whole blood is extracted into fresh, like platelet is plasma. Then remember, we have platelets and we have plasma. From this plasma, we can derive FFP, fresh frozen plasma. From this, we can get cryoprecipitate. So it is like an ultra filtered product. And this ultra filtered product, what it will have? It will have a fibrinogen. They ask you, actually, they're asking question like all are component of cryoprecipitate except. So it will have fibrinogen, right? This will have, I can say, factor 13. This will have, I can say, clotting factor number 8. This will have a von Willebrand factor, and it will have a fibronectin. So these are the constituents that we see in cryoprecipitate. So that's why we can use this in A, fibrinogenemia. We can use this in hemophilia A, that is due to factor 8 deficiency. We can use this in von Willebrand disease. So fibrinogen is the product? Yes. It's a true statement. Clotting factor 8 is a component? Yes. Clotting factor 9? No. So that's why we don't. Clotting factor 9 deficiency is hemophilia B. So you can't use this in hemophilia B. Von Willebrand factor, yes. So 1, 2 and 4, these are the component of cryoprecipitate. So 1, 2 and 4. So this will be the answer, option B. 1, 2 and 4, clear? Okay, coming to next one. Following virus can be transmitted by a transfusion of infected blood. Again, this simple one. This is a very simple question. Like whenever I see this type of question, like these are the like those easy things in exam. So remember, they have not given hepatitis A and E. So, you know, hepatitis A and E, they spread by fecal-oral route. So remember, hepatitis B, hepatitis C. Then HIV, you already know, HIV can be transmitted by blood transfusion, by blood products, and by sexual route also. Then remember, this is parvo. This is parvovirus B90. Then remember CMV, cytomegalovirus, and we have HTLV, human T cell lymphotropic virus, HTLV1. Actually, HIV was called HTLV3 before. So HTLV1 and HTLV, this HIV is HTLV3. Then we have West Nile virus. So these are the list of virus which can be transmitted via infected blood. So hepatitis B, C, HIV, parvovirus, so 1, 2, 3, 4, all can be transmitted by infected blood. Very, very important. Okay, following is also with low MCV. So they're asking you low MCV. So low MCV, remember we have, I told you, mnemonic Sheetal. Sheetal means as a sideroblastic, I is iron deficiency anemia, T is thalassemia, A is AOCD, anemia of coronary disease, L is lead poisoning. So sickle cell anemia is normocytic. So here you will see a normal MCV. B12 and folate. Here you will see these are macrocytic. You will see a high MCV. So T is thalassemia. Thalassemia is an example of microcytic anemia. So in microcytic, what you will see MCV value low. Low means how much? It's less than 80 femtoliter. Normal value is 80 to 100. In macrocytic, you will see more than 100. Okay, now understand. Iodine has complex effect on thyroid function, very high concentration of iodine. Inhibit thyroid hormone synthesis and release. So if you give too much iodine at one time, this effect is what we call this as Wolff-Chaikoff effect. The opposite to this means high concentration of iodine gradually, right? This will increase hormone synthesis and release. That is what we call Jode-based effect. Jode-based effect is opposite of this. So this will increase. So these two effect like sometime, for example, I can say Wolff-Chaikoff effect we use in radiation oncology or in radioactive isotopes. So whenever you are giving iodine analog to, I can say for ablation of thyroid gland, that radioactive ablation, we can use this effect, Wolff-Chaikoff effect. Similarly, like Jode-based effect, like if you continue consuming iodine salt So there is a chance like we can become a hyperthyroid in future. That's like it will increase iodine uptake and synthesis. That is what we call Jod-based effect. Is it clear? Again, thyroid was a routine exam. So following a pharmacology agent, propranolol, sodium hypodate, propylthiourine. The following are used treatment of thyrotoxic crisis. So basically, you should know thyrotoxic crisis means it is an example of hyperthyroidism. So they are asking you which drug you will use in hyperthyroidism, right? So understand this. Now, when I see this question, propranolol we use in treatment of hyperthyroidism. Sodium hypotate we use, and propylthiouracil, methimazole, carbimazole, these are actually more preferred drugs. So this is also used. Liothyronine is thyroid analog. Already patients having hyperthyroidism, you will not use this drug. Clear? So liothyronine is not used. So which can be used in crisis? We can use 1, 2, 3. 1, 2, 3. Now consider the following pharmacological agent: liothyronine, levothyroxine, carbimazole, sodium hypodate. Now they're asking you which we use. They're asking you which of the following may be included in treatment of mixed edema, coma. So mixed edema, coma is a complication of hypothyroidism. So they are asking you question on which drug we can use in hypothyroidism. So we can use levothyroxine, that is the drug of choice. In like severe state, we can use liothyronine, that is again next preferred drug. Carbimazole and sodium hypotate, these are used in hyperthyroidism. Is it clear? So these two are not used. So answer for this question will be 1 and 2. 1 and 2 is option number B. Okay, following statement are correct for the treatment of chronic hepatitis B with pegylated interferon. So let's see option one by one. Pegylated interferon is poorly tolerated drug as compared to nucleoside analog. So understand this. So if you see like these interferons, when you these are the drugs which can produce a lot of side effects. So that's why they are actually poorly tolerable drugs. So nucleoside analog on the other hand, like these are easily tolerated drugs. Resistant to, so they are asking you about correct statement. So this is a correct statement. Coming to next one, resistance to treatment with pegylated interferon is common. No. Actually, we use them whenever there is resistant to nucleoside analog. These are used whenever in resistant cases only. Nowadays, we don't use interferon. They are used only in resistant cases. So this is the wrong statement. Resistance is not common. It is not useful in patient with cirrhosis. So understand, whenever you will give this in a patient with cirrhosis, they can produce sometimes more side effects. So it's actually again a true statement. It is administered every week for 48 weeks. That is the treatment of hepatitis B. So actually they are given for 48 weeks. So 1, 3 and 4, these are 3 correct statements. Moving to next one, which of the following are recommended for management of tumor lysis syndrome. So understand, tumor lysis syndrome, this is a complication that we can see with the tumor. So this can lead to electrolyte imbalance. So you can see patient will develop hypocalcemia, and there will be all other signs will be more, like there will be hyperkalemia, there will be hypernatremia, there will be increase in uric acid. So basically, so uric acid is more. So now they are asking you question how you will manage. So can we give febuxostat? Yes, we can give. Can we give resburicase? Yes, we can give. Can we give IV fluid? Yes, whenever we give fluid, this will dilute these crystals. So remember, again, IV fluid we can use. Can we give alkalization? No. Remember, again, alkalize, when you try to alkalize the urine, this can even precipitate some crystals. That's why this alkalization is avoided. So just remember, we can use this, we can use this, we can use this. Alkalization is not done. So 2, 3, 4, these are correct options. 2, 3, 4. Okay, again, this was like a straight away question. Whenever you read Edson, you can divide seizure into focal and generalized. So focal seizures, like you can see Jacksonian march. That's the march seizure, which will start from distal part, then slowly this will march upwards. Seizure will start from fingertips, and this will move in an ascending order. Then we have torse paralysis, like a patient will have seizure, this followed by extreme weakness of the body. We call this torse paralysis. And third is sometimes patient will have continuous partial seizure. That's called epilepsia partialis continua. So these 3, like 1, 2, 3, all these are example of focal seizures. And remember, the drug of choice for all these 3 conditions will be carbamazepine. So 1, 2 and 3, all these are example of focal seizures. Typical absence seizures are characterized by, so remember, in typical absence, these are the types of seizures which are seen in children. So we also call them daydreamers. So attacks are very brief in nature, generally noticed by school teachers. So in EEG, what you will see 2 to 4 hertz spike and wave pattern. So 2 to 4 means 3 years coming in the between. So this is the correct option. These type of seizures are very brief attacks. So there is no post-ictal phase. There is no post-ictal deficit. There is no post-ictal confusion. Nothing is there. So post-ictal confusion is not seen. Multifocal structure abnormalities of the brain. So whenever you do like CT or MRI of the brain, remember brain structure is absolutely normal in case of absent seizures, and these are the seizures which actually are resolved totally by 20 years. So whenever this child will become adult, this seizure will disappear. So there is no multifocal structure abnormalities. Less responsive to anticonvulsant as compared to atypical absence. Understand this. If you see typical absence, they are in fact more responsive. In typical absence, whenever you start the drug with one drug, they are controlled. Atypical absence, here patient will have mental retardation. Here there is less response. So remember, they are not responsive. They are not less responsive. They are in fact more responsive with antiepileptic. Remember atypical absence. Here you will notice IQ will be decreased, and here you will see less response. So here sometimes we have to use combinational drugs. Yeah, and typical absence is having good response with antiepileptic drugs. Following are contraindication to thrombolize in acute ischemic stroke. So again, let's see the question. Recent head injury. So suppose like there's any head injury in last 1 to 3 months. In some books it's given 1 month, some books it's mentioned 3 months. That's an absolute contraindication. Recent MI. Again, this is like a controversy. So let me just clear this. Recent MI which was treated with thrombolysis. That should be given the option. Recent MI which was treated with thrombolysis, not with PCI. So remember, recent MI is also, I can say this is a contraindication. So they're asking you, following are contraindications. So recent head injury is a contraindication. Recent MI with thrombolytic use, that's also contraindication. Hypertension is also a contraindication, but the range here is given 150 by 100. This is not a correct range. Remember, hypertension when BP is more than 185 by 110. So this hypertension is the contraindication, not this range. And GI bleeding the last is also contraindication. So again, this option 3 is wrong. So 1, 2 and 4, these are the absolute contraindication, 1, 2 and 4. Which of the following distinguish axonal degeneration from segmental demyelination on electrophysiological study? We call them EPS, so understand this. So remember, the distal latency is normal in axonal degeneration and prolonged in segmental. That is a true statement. Conduction velocity is slow in axonal. No. Conduction block is present in axonal and absent. No. Temporal dispersion is prominent in segmental, not in axonal. Again, this is the wrong statement. So correct answer for this question will be A. Following drugs help to maintain abstinence by reducing craving for alcohol. So here we have a mnemonic, that is NOTA. NOTA means we can use naltrexone. That is an opioid antagonist. We can use ondansetron. That is antiemetic drug. Then we have topiramate. Topiramate is anti-epileptic drug. And we have A4, acamprosate. Okay, like some of you are thinking about a disulfiram, that is not for maintaining abstinence. That is called anti-abuse. Means that is a drug that is given for addiction, but not for maintenance. So this is these are the drugs which are called anti-craving drugs. These are the drugs which will reduce the craving for alcohol. The correct answer will be acamprosate. Apomorphine is a drug that we sometimes use as a rescue therapy in Parkinson. Atropine, you know, well, like we use basically this in ophthalmology, and we use atropine in a patient who is having bradycardia. Then we have thiopurine, that is used in rheumatology a lot as an immunosuppressant drug. BCR-ABL oncoproteins, understand this. So we have BCR-ABL. ABL is Abelson leukemia, and BCR is B cell receptor. So understand this BCR-ABL gene, like they are located at chromosome 9 and 22. This fusion of these chromosome or this BCR-ABL gene, this will produce a protein called protein 210. This protein 210 is the protein which is having tyrosine kinase activity, and this will activate many processes of the body. So we have a drug. If you inhibit this tyrosine kinase, then we can also treat this condition, and this is ultimately leading to CML. So basically they are asking you a question like this 922 chromosome, how we write like this? We write like this. What we call this translocation 922 or Philadelphia chromosome. So they're asking you like, they're having which activity, which of the following enzymes? So answer is tyrosine kinase. And if you ask me like, there's one more question, okay, that will come there. Like here, what we use tyrosine kinase inhibitors. So we use drugs like tinib, imatinib, dasatinib, nilotinib, ponatinib. These are the drugs. Okay, next question is same. Imatinib, dasatinib, nilotinib, ponatinib. These are tyrosine kinase inhibitor, right? So they will inhibit tyrosine kinase. So remember, NIBs are tyrosine kinase inhibitor. Easy one. Helicobacter pylori is associated with development of the following lymphoid malignancies. So understand, Burkitt lymphoma is due to CMYC gene mutation. Hodgkin lymphoma, so we have different types like lymphocyte predominant, nodular sclerosis like lymphocyte rich, depleted, a huge list. Then again, Hodgkin lymphoma can also be due to some genetic or some environmental causes. But the Helicobacter pylori will lead to something called maltoma. Maltoma is mucosal associated lymphoid tissue lymphoma. Adult T-cell leukemia is something that is due to HTLV1, human test T-cell leukemia virus 1, HTLV1 virus infection. So correct answer for this question will be option C, maltoma. Okay, coming to next one. A 56-year-old male. So let us see this question. It's important. Chronic heavy smoker, present with breathlessness. On examination, pulse is 90, that's okay. BP is also okay. So I'm not highlighting this. Pansystolic murmur. This is very, very important. Pansystolic murmur is showing Carvalho sign with murmur getting louder on deep inspiration. Which one of the following statement is true regarding examination of JVP in him? So basically they are telling you like patients having this pansystolic murmur, Carvalho sign. So it is actually a case of TR. So diagnosis I made, that is called TR. TR means tricuspid regurgitation. So they are asking you like what is the sign that we see? So understand this, V wave is not attenuated. What we see in TR, we see like a V wave and C wave, they merge together. And the peripheral finding, what we use the term for this is called Lance's signs. Lance's sign that we see. So V and C wave, they merge together. So it's a case of tricuspid regurgitation. Okay, again an easy one. Following is manifestation of vascular phenomena. So remember, there are in Duke's criteria, we have major criteria, minor criteria. So like an echographic finding or blood culture finding, they are included in major criteria. In minor, what we have some vascular phenomena, and then we have some immunological phenomena. So understand this. Here they are asking question on vascular phenomena. So remember, osseous node roth spot glomerulonephritis. These are immunological phenomena. And Gyane lesion is a vascular phenomena. Is it clear? So this is a vascular phenomena, Gyane lesion. Volume of air remained in the lungs after the normal expiration. What we call this? So it's again an easy one. Easy type of question that they have asked in exam. So what we call this? Remember, this is called FRC. FRC means your functional residual capacity. FRC. So easy question. Okay, this is a topic which is I've been asking in many different exams like in NEET, PG, FMG, and ICT, all these places they are checking this topic. So they are asking you like investigation of choice for early follow-up in patient with H. pylori drugs. So understand. The question is for follow-up, not for diagnosis. So whenever they are asking question on follow-up, so understand for follow-up, we will not use invasive test or endoscopic based test. So urea breath test is a test that is non-invasive, so that is used for follow-up. Rapid urease is invasive endoscopic test, so again it is not for follow-up. Stool H pylori antigen, again that is also used for diagnostic, not for follow-up. Serology, same thing. We can also use, but they are not preferred for follow-up. So for follow-up, the preferred test will be urea breath test. Most common non-pancreatic site tumor of Zollinger-Ellison syndrome, we call this gastrinoma. So remember, the most common non-pancreatic site is duodenum. It is duodenum. And remember, like most of these tumor in the duodenum site, what Harrison says, like they are mostly benign in nature. Following a risk factor for hepatitis C. So fecal-oral transmission is seen with hepatitis A and E. Remember, vowel, A, E, I, O, U, vowel will hit the bowel. Bowel means fecal-oral. IV drug abuse can cause this? Yes, correct. Vertical transmission can cause this? Correct. Sharing toothbrush, razors, so sometimes there can be blood, so it can be due to sharing toothbrush and razors. So correct answer for this question will be 2, 3, 4. 2, 3, 4. Most common cause of shock in severe acute pancreatitis. So remember, in any type of pancreatitis, like with severe acute means generally the common cause of shock will be hypovolemia. That is hypovolemic type of shock is seen. Is it clear? So in pancreatitis, remember, hypovolemic shock is common. That is resulting from third space loss. Okay, so this is like SBP, spontaneous bacterial peritonitis, very commonly seen as a complication in a patient with CLD. CLD means patient is having liver cirrhosis. So sometimes what happens is, like if you see like WBC's number are more than 500, and out of this neutrophils, they are more than 250, then we make a diagnosis of SBP. Remember, the most common agent for this condition is E. coli. And how we manage this? So we have to use cefotaxime. If cefotaxime is not available, the alternative to this is ceftriaxone. And for prophylaxis, I am writing PX. For prophylaxis, what we use norfloxacin. So this is something that you should know about spontaneous bacterial peritonitis. Serological marker detected during window period, I have already discussed this. In window period, what we have IgM anti-HBC. This is the only marker in window period. This HBE antigen, it's a marker for active viral replication. IgG is for chronic. And this is like for when the disease is cured. Thickened ventricular wall. This is like, again, many of you I know made a mistake here. Thickened ventricular wall with normal diastolic function. So I think most of you, like like in restrictive cardiomyopathy, there will be some diastolic dysfunction. In fibros also. So most of you have marked the answer hypertrophic cardiomyopathy. So remember, hypertrophic cardiomyopathy will have thickened ventricular wall, but there will be enlargement of chambers, and these chambers later on will not have normal diastolic function. So that's why it's not the answer. It is like many people or many individuals, what Harrison says, like people with endurance sports, they have some sort of thickened ventricular wall, but diastolic function is normal. So that is called athlete's heart. Okay, then we have a question like, in which of the following does paradoxical splitting occur? So understand. So this question like came many time in exam. This is like a topic they're asking again and again. So we can see paradoxical splitting in severe aortic stenosis. This is a correct statement. So we can see this in right bundle branch block. No, we actually see this in left bundle branch block. And this right ventricular pacing, this will mimic LBBB, left bundle branch block. So here also we can see this. In hypertrophic obstructive cardiomyopathy also you can see this. So correct answer will be 1, 3 and 4. 1, 3 and 4. Okay, a patient with following examination, a soft systolic murmur at the left sternal border with raised JVP, prominent CV wave, murmur increase in intensity on deep inspiration. What is the most likeliest diagnosis? So understand again, like prominent CV wave, that is seen where in a patient with TR, tricuspid regurgitation. This is Kussmaul. Kussmaul sign is seen in many conditions, but it's more classical for constrictive pericarditis. Straightforward question. Following disease have predominantly large, like I told you, 2T. 2T means temporal and Takayasu. So temporal arteritis is also called as giant cell arteritis. So that is an example of large vessel vasculitis. Is it clear? So understand this. This polyarteritis nodosa is medium vessel vasculitis. Osborn waves in ECG with elevation of J point, where we see. So Osborn J, where we see these waves in hypothermia, in a patient with hypothermia. Coming to next one, a decline in total lung capacity to more than 80% of patient predictive value. This is like a decline in TLC. Again, in the question they're asking about TLC, not about FEV. They're asking about FEV or FVC ratio. They're asking you TLC. It's very classical in a patient with restrictive lung disease. Coming to next one, a 28-year-old male is suspected to have hypertrophic obstructive cardiomyopathy. Following statement are likely to hinder to examination. So maneuvers that decrease the preload will increase the murmur intensity. So that is true. Actually, those maneuvers which decrease preload, they will that decrease the preload will intensify the murmur. This is a true statement. Coming to next one, if you see like maneuvers that decrease the afterload will cause a decrease intensity. No. Murmurs of HOCM becomes, I think here in the option there was soft, becomes softer with passive lag raise. So that is also a true statement if it is softer given. And murmur of HOCM will becomes louder with squatting. No. So here in this question I can see only 1 and 3. These are two correct options. Following regarding inflammatory bowel disease is correct. Rectum is always involved in Crohn's disease. Crohn's disease can involve any part from out to anus, right? And rectum is not always involved. In fact, it is spared. It is not always involved. So they are asking you correct statement. Fistula formation is seen in ulcerative colitis. No, fistula. These are features mainly of Crohn's disease. They are seen in Crohn's disease. Stricture formation is also seen in Crohn's disease. Perianal disease is common in Crohn's disease. So that can be a true statement. Perianal disease is very common. Chila dual body is again a histological marker of which tumor. That is a straightforward question. It is for endodermal sinus tumor. So the following blood values of iron deficiency anemia. Serum iron is less than. Serum iron is less. That is correct. TIBC is less. No. TIBC, remember TIBC is inversely proportional to ferret. So TIBC is not less. It is increased. Remember TIBC is increased. Percent saturation is less. True. Ferritin is below 30. Yes. True. So 1, 3, 4. These are correct. Coming to next question, with the following are correct regarding blood substitute. So understand, these are biomimetics. So remember, they are substitutes. So they are mimicking some biological agents. So this is the true statement. They are extensively used in war injuries. No, they are not easily available. So they are not extensively used. They are made up of perfluorocarbon emulsion. True. They are hemoglobin based. True. So 1, 3, 4. These are correct options. Coming to next one. If on amniocentesis, alpha fetoprotein is found to be elevated. Raised alpha fetoprotein is a marker for neural tube defect. Neural tube defect. Okay, with reference to occupational cancer, consider the following statement. Skin cancer is common occupational hazard in workers employed in nickel and chromium. The person exposed to nickel and chromium will have risk of lung cancer, not skin cancer. Cancer, bladder is an occupational hazard in worker employed in dye stuffs and dyeing industry. Yes, bladder cancer is very common in dye industry, dye factory. In dye, because they can use like benzidine derivative or aromatic amine derivative in dyes is very common. Leukemia can occur on long exposure to benzol. That is true. And lung cancer is typically found in workers in electric cable industry. So electric cable industry, generally lung cancer is not seen. Here what we can see, we can sometimes see like angiosarcoma of liver because they this electrical cable, they use PVC pipes. So correct answer will be 2 and 3, and this 2 and 3 is given. These two are correct. Zollinger-Ellison syndrome is characterized by which of the following? So here you will see fulminant gastric ulcers. Yes, you can see these gastric ulcers. You can see recurrent ulceration despite treatment. Yes, patient can develop recurrent refractory gastric ulcers. It is a non-beta islet cell tumor. Yes, beta islet tumor is insulinoma. Recurrent episodes of dysentery. Dysentery means blood is there in that area. No, here generally, in fact, we see watery diarrhea, not dysentery. There is no blood or mucus. There is only watery diarrhea. So 1, 2, 3, these are correct statement. Following statements with regard to familial adenomatous polyposis. It is associated with mutation of APC gene located on short arm of chromosome 5. In fact, it is located in long arm. So it is a correct statement. It is inherited as autosomal dominant, not recessive. This is a wrong statement. It is inherited as autosomal dominant in nature. It is associated with 100% lifetime risk of development of colorectal carcinoma. That is a correct statement. Congenital hypertrophy of retinal pigment epithelium is present in half of the cases of familial adenomatous. That's also a correct statement. So 1, 3, 4 is correct answer. These are correct. Remember, the mode of inheritance is autosomal dominant, not autosomal recessive. Who among the following have general second phase characterized by progressive massive fibrosis? So massive fibrosis, where we see progressive massive fibrosis, we see in a patient with cold worker pneumoconiosis, also called as anthracosis. Tall, thin adolescent boys found to have gynecomastia and small testes. Blood testosterone levels is undetectable. Serum FSH are elevated. We call this hypergonadotropic hypogonadism. So what is the diagnosis? It is a case of Klinefelter. How we write? XXY, 47 XXY. This is like a normal male. You can see this is Turner syndrome. This is Down syndrome. That's seen in pediatric population. Following correctly describe the mode of inheritance of hemophilia B. So both hemophilia A and B both are X-linked recessive. And that's why they are seen in boys. They are seen in boys, not in girls. Answer is simple. Which of the following condition characteristically may present with triad of hemolysis? Hemolysis you can see in all these: pancytopenia and venous thrombosis. So G6PD you can see hemolysis, but rarely you will see pancytopenia. In hereditary spherocytosis, you can see hemolysis, but again, very rarely you will see pancytopenia and venous thrombosis. Hemolytic uremic syndrome, again, you can see hemolysis. You can also see pancytopenia very rarely, but venous thrombosis extremely rare. So answer is PNH. So PNH is a condition where you can see hemolysis, pancytopenia, and venous thrombosis. I know many of you are finding aplastic anemia. Aplastic anemia, there is no hemolysis. There is, in fact, there is anemia due to decreased production. Is it clear? Following are correct regarding alpha-1 antitrypsin deficiency. So prolonged jaundice in neonates. So remember, this alpha-1 antitrypsin is a protein that is protecting two organs. One is your lungs, second is your liver. So either if lungs are damaged, patient can develop pan-HN or emphysema. If liver is affected, then patient can develop cirrhosis. So there can be prolonged, the common gene that we have is PIM. So when this is totally mutated, we will get the most severe variety we call this PIZ. So in this, if this is like this type of variety, then patient can develop prolonged jaundice. That's a true statement. If there is a total mutation from MM to ZZ. Pulmonary adulthood emphysema in adults. That's a true statement. Patient can develop emphysema. Paniculitis is seen rarely. Rarely you can see this like soft tissue fat inflammation. We call this paniculitis. It can also be seen, but rarely. Again, autosomal dominant, no. This is the condition which is autosomal recessive in nature. So this is the wrong statement. 1, 2, 3, these are correct. Moving to ischemia reperfusion. The ischemia of reperfusion is characterized by build-up bicarbonate, no. Acute mesenteric thrombosis, no. Thromboembolic angiopathy, no. It is characterized by hypoxia and activation of inflammation. So these are the sets of questions which we have discussed. Like again, it's like a club of many things. You can see alone medicine is not enough. To understand this medicine, we have to integrate with all the pre and paraclinical subject, especially microbiology, pharmacology. So in my opinion, this was a subject. These were two very important subject, and even there were a few questions on physiology as well. So these are the topics which you should know. Only then you can understand the things about I can say medicine in this type of UPSC paper. So it is not like a core of a medicine. They are asking you many questions on infectious disease and diabetes, thyroid, hepatitis. These were the high yield topics. So I hope to see you when your result come out. So if you need any help, so those who will crack the exam, to how to crack interview, what type of question can be asked in the UPSC CMS interview, you can ask your queries in the comment box. So I'll be glad to answer, because there are some sets of questions which they ask in Viva, in the, I can say, in UPSC round 2. That will be an interview. We call this a simple interview, but they sometimes ask some tricky questions. So you can ask us what type of question they can ask you. So you should prepare some common topics. So they can ask you like management of MI, they can ask you some common drugs, they can ask you diabetes, they can ask you DK. So these are some things which they tend to ask in interviews. So say you, if you have any doubt, you can ask in the comment box, or we will conduct a special session in the YouTube to prepare you for those candidates who will clear this UPSC theory paper for their interview. Thank you so much. Keep working hard. Bye-bye.
Hello friends, good evening, good morning, good afternoon, whenever you are watching this video. Welcome to the discussion of questions of pediatrics which have come in the CMS exam. So जल्दी शुरू करते हैं, and as usual the favorite topics are going to be development, immunization. तो ये हमारा बिल्कुल thorough होना चाहिए. तो शुरू करते हैं. सबसे पहला question, the upper limit of age for attainment of visual fixation is. ठीक है, again this is one क्वेश्चन जो कि अगेन डेवलपमेंट से उठ के आया है, तो हमको अच्छे से पता होना चाहिए. एज ऑफ अटेनमेंट भी पता होनी चाहिए और अपर एज भी पता होनी चाहिए, क्योंकि उससे पता पड़ता है कि हमारा रेड फ्लैग साइन क्या है. तो विजुअल फिक्सेशन यूजुअली कम्स एट अराउंड 1 month ऑफ एज. विजुअल फिक्सेशन अलोंग विद फॉलोइंग, सो दैट कम्स एट 1 month ऑफ एज, एंड अपर लिमिट मानी जाती है 2 months. ठीक है, सो दीज आर द वेरी इंपॉर्टेंट माइलस्टोन्स जिसकी हमें यूजुअल एज एंड अपर लिमिट पता होनी चाहिए. सो विजुअल फिक्सेशन आप देख सकते हो, 2 months अपर लिमिट है. वोकलाइजेशन 3 months पे आती है, 6 months अपर लिमिट है. सिटिंग विद सपोर्ट 8 months पे आता है. 10 मंथ्स अपर लिमिट है, स्टैंडिंग विद असिस्टेंस 9 मंथ्स पे आता है और 12 मंथ्स अपर लिमिट है, हैंड्स एंड नीज क्रॉलिंग वी नो 8 मंथ्स पे आता है एंड 14 मंथ्स अपर लिमिट है, स्टैंडिंग अलोन दैट इज विदाउट सपोर्ट आता है 12 मंथ्स पे एंड अपर लिमिट कुछ मानी जाती है 17 मंथ्स और सो, राइट। वॉकिंग अलोन आता है 15 मंथ्स पे, अपर लिमिट इज 18 मंथ्स, वेरी वेरी इंपॉर्टेंट। एंड सिंगल वर्ड्स यूजुअली दे कम बाय 12 मंथ्स दैट इज 1 ईयर ऑफ एज एंड अपर लिमिट मानी जाती है हमारी 18 मंथ्स, राइट। सो ये हमको अपर लिमिट भी अच्छे से याद होनी चाहिए। यहाँ पे हमारा क्वेश्चन विजुअल फिक्सेशन का है तो हम इसी पे कॉन्सेंट्रेट करेंगे, तो हमारा आंसर होना चाहिए 2 मंथ्स, राइट। तो इसका करेक्ट आंसर होगा सी ऑप्शन दैट इज 2 मंथ्स। Now let us move to the other question. Again a development question. A child develops stranger anxiety at 2 to 3 months, 4 to 5 months, 6 to 7 months, 8 to 9 months. सो हमको पता होना चाहिए कि स्ट्रेंजर एंजाइटी ये तो बहुत बार पढ़ाया जाता है, 6 to 7 मंथ्स पे आती है। स्ट्रेंजर एंजाइटी का मतलब है कि बच्चा पहचानता है कि फादर कौन है, मदर कौन है, केयर गिवर कौन है, बेसिकली जो भी उसके साथ रह रहा है, वो दद्दू हो सकते हैं, दादी हो सकती है, जो भी उसका केयर गिवर है, जो रोज बच्चा जिसको देखता है उसकी शक्ल पहचानता है एंड कोई भी और शक्ल आ जाए जैसे कि डॉक्टर की, पीडियाट्रिशियन की शक्ल आ जाए, द चाइल्ड स्टार्ट्स हाउलिंग, राइट। तो इसे कहते हैं स्ट्रेंजर एंजाइटी और ये 6 to 7 मंथ्स पे आती है, ये हमको पता होना चाहिए, राइट। ओके, देन लेट अस मूव टू द नेक्स्ट क्वेश्चन एंड दैट इज consider the following statements with respect to developmental milestones at 9 months of age. 9 months of age पे हमारा बच्चा क्या क्या कर सकता है, देखें जरा। At this age the child develops immature pincer grasp. Is this correct? Of course this is correct. Immature pincer grasp मतलब pincer grasp की शुरुआत ही 9 months पे होती है, जो कि 12 months पे जा करके mature pincer grasp में तब्दील हो जाती है, that means develop हो जाती है, right? तो ये तो फर्स्ट स्टेटमेंट हमारा करेक्ट है और हमसे करेक्ट ही पूछा गया है, ठीक है, करेक्ट ही पूछा गया है। सो देन एट दिस एज द सेकंड स्टेटमेंट इज एट दिस एज द चाइल्ड कैन से बाई सिलेबल्स मामा या डाडा। क्या ये करेक्ट है? बिल्कुल करेक्ट है। आपको पता होना चाहिए, जैसे बताया कि वोकलाइजेशन 3 मंथ्स पे शुरू होती है, मोनोसिलेबल्स या उससे पहले अगर हम बोले लेडी गागा, दैट इज हाउ आई टीच द स्टूडेंट्स की लेडी गागा आती है 5 मंथ्स पे, मतलब आगूगा ये आता है 5 मंथ्स पे, इसको याद करो, लेडी गागा आती है 5 मंथ्स पे। 6 मंथ्स पे बच्चा मोनोसिलेबल्स बोलने लग जाता है, मा पा दा, these are monosyllables and 9 months पे बच्चा bisyllables बोलने लग जाता है। So this is an absolutely correct statement, दोनों correct हो गए। Then third कहते हैं at this age, that means 9 months they are talking about, the child can wave bye bye. Of course that's a very very important milestones। इसको कैसे आप याद करोगे? तो जब मेरे पास बच्चे आते हैं क्लिनिक में, and 3 months 4 months का बच्चा, पेरेंट्स खुश होके जा रहे हैं एंड बोल रहे हैं चलो डॉक्टर को बाय बाय करो, आई ऑलवेज टेल देम जब आप MMR का वैक्सीन लगवाने आओगे तब बच्चा बाय बाय करेगा, एंड दैट मीन्स 9 मंथ्स। सो दैट्स व्हाट यू हैव टू रिमेंबर कि 9 मंथ्स पे हम MMR का वैक्सीन भी लगाते हैं एंड बच्चे से बाय बाय भी लेते हैं, जो कि उसका एज अप्रोप्रिएट है। सो नो एक्स्ट्रा प्रेशर बिफोर द एक्चुअल डेवलपमेंट ऑफ माइलस्टोन शुड बी पुट ऑन द चाइल्ड, राइट। एंड बच्चे को एकदम से बाय बाय नहीं आ जाएगा, ये भी पता होना चाहिए दैट अल्टीमेटली इट इज द the environmental stimulation. If the mother does not engage in teaching the child will not do bye-bye. This thing also has to be reinforced in the parents. Please remember. So 9 months पे bye-bye अपने आप नहीं आ जाएगा, पेरेंट्स ने, मदर ने सिखाना है तभी आता है, वो बच्चा रिसेप्टिव होता है तो 9 मंथ्स पे बच्चा वेव करता है बाय बाय। सो दिस इज एब्सोल्युटली राइट आंसर। अब इसमें पूछा हुआ है कौन से करेक्ट है, तो हमारे तो तीनों करेक्ट है। सो द करेक्ट ऑप्शन इज गोइंग टू बी द डी ऑप्शन, दैट इज 1, 2 and 3। ठीक है। नेक्स्ट क्वेश्चन इज व्हाट आर द अपर एज लिमिट्स बाय विच अ चाइल्ड शुड स्टार्ट वॉकिंग अलोन एंड बी एबल टू स्पीक वर्ड्स। तो वॉकिंग अलोन की नॉर्मल एज अटेनमेंट होती है 15 मंथ्स, ये याद रखो दोस्तों। 12 मंथ्स तो आपको पता है वॉक्स विद 1 फिंगर हेल्ड। हमें कैसे याद है कि जब बच्चा 1 साल का होता है, एक उंगली पकड़ के, माँ की एक उंगली पकड़ करके पार्टी में केक टेबल पे के पास जाकर के केक काटता है अपना बर्थडे का। ऐसे याद करिए, इसे कहानियां बनाओगे तो याद रह जाती है। सो दैट इज हाउ इट इज डन एंड इट इज रिमेंबर्ड दैट एट 12 मंथ्स ऑफ एज द चाइल्ड वॉक्स विद 1 हैंड और 1 फिंगर हेल्ड। 15 मंथ्स पे इंडिपेंडेंट वॉकिंग नॉर्मली शुरू हो जानी चाहिए, पर हमसे क्या पूछा है, हमसे अपर एज लिमिट पूछा है। अपर एज लिमिट इसके लिए होती है 18 मंथ्स। प्लीज रिमेंबर, इसकी अपर एज लिमिट अगर मैं अपर एज लिमिट करके लिखूं तो वो होती है 18 मंथ्स। व्हाट अबाउट एबल टू स्पीक वर्ड्स? एबल टू स्पीक वर्ड्स की भी अपर एज लिमिट 18 मंथ्स बोली जाती है। एट 1 year ऑफ एज द चाइल्ड हैज अ वोकैबुलरी ऑफ अराउंड 2 to 3 वर्ड्स, राइट। एंड इसकी अपर एज लिमिट 18 मंथ्स मानी जाती है, तो इसमें हमारा आंसर डी ऑप्शन हो जाएगा, जिसमें बोथ ही 18 मंथ्स है। 18 मंथ्स इज द अपर एज लिमिट फॉर वॉकिंग अलोन एंड फॉर स्पीकिंग, एबल टू बी स्पीकिंग 2 to 3 वर्ड्स और वर्ड्स एज सच, ठीक है। ओके, सो दिस इज इट। देन आगे चलते हैं नेक्स्ट क्वेश्चन पे। A child presents to the emergency following ingestion of around 20 ml of kerosene oil about 40 minutes back. The child appears stable. Which one of the following measures should be done for the management of this child? अब इसमें आपको पता होना चाहिए कि हाइड्रोकार्बन इंजेक्शन है, केरोसिन ऑयल यू नो, एंड फॉर ऑल दैट यू नो केरोसिन के साथ एक और प्रॉब्लम होती है, दैट इट इज हाईली वॉलेटाइल, नंबर 1, एंड नंबर 2 द विस्कोसिटी इज वेरी लेस। और सीधा सीधा फंडा ये लगता है, अगर बच्चा हाइड्रोकार्बन इंजेक्शन करता है, जो कि मोस्ट कॉमन फॉर्म ऑफ पॉइजनिंग मानी जाती है, वाई? बिकॉज ऑफ द स्मेल एंड बिकॉज ऑफ द समटाइम्स अट्रैक्टिव कलर, केरोसिन ब्लू कलर का आता है, एंड अगर ट्रांसपेरेंट बॉटल में रखा गया तो बच्चा बड़े आराम से पी लेता है, एंड स्पेशली इफ इट इज केप्ट एट सम प्लेस विच इज एक्सेसिबल टू द चाइल्ड। तो ये 2-3 फैक्टर्स होते हैं जिसकी वजह से हाइड्रोकार्बन पॉइजनिंग काफी कॉमन होती है। अब वेरी इंपॉर्टेंटली यू शुड नो अबाउट केरोसिन इज दैट केरोसिन के साथ प्रॉब्लम क्या है। प्रॉब्लम जैसे मैंने बताया, लो विस्कोसिटी है, जिससे कि इंजरी होने के चांसेस बहुत बहुत बढ़ जाते हैं। प्लीज रिमेंबर दिस। एंड सेकेंडली हाईली वॉलेटाइल है। हाईली वॉलेटाइल का क्या मतलब है कि अगर बच्चे ने ये पी लिया एंड उसके बाद हमने वॉमिटिंग करवाने की कोशिश करी, इफ वी ट्राई टू इंड्यूस वॉमिटिंग, देन दिस चाइल्ड माइट एस्पिरेट द कंटेंट्स रिजल्टिंग इन एस्पिरेशन निमोनिया, अ वेरी वेरी कॉमन presenting feature of kerosene poisoning. So that is why it is always said that never ever attempt emesis in a child who has taken kerosene, number 1, and even do not attempt gastric lavage, because you might induce aspiration pneumonitis even if the child has not initially had it, right? तो ये 2 चीजें हमने याद रखनी है। अब हाउ डू वी मैनेज अ चाइल्ड विद केरोसिन पॉइजनिंग? प्लीज रिमेंबर कि जैसे ही बच्चा आता है, हमारे पास 2 ऑप्शंस हो सकते हैं, या तो बच्चा सिम्टोमेटिक है या एसिम्टोमेटिक है। लेट अस अज्यूम कि ये बच्चा एसिम्टोमेटिक है, बिकॉज हमारे क्वेश्चन में अगर आप देखो, द चाइल्ड अपीयर स्टेबल, दैट मीन्स अब 40 मिनट्स हो गए हैं, अभी तक तो बच्चे को कुछ नहीं हुआ, तो अब हम क्या करेंगे? सो जब एसिम्टोमेटिक बच्चा है, मतलब स्टेबल है, तो आप all the clothes remove karoge, and you will wash the skin very importantly, and there is no gastric lavage or induced emesis, that I have already told you, and very importantly you will get a x-ray done, although please remember x-ray में infiltrates ज़रूरी नहीं है उस टाइम आए, usually takes around 6 hours to develop, पर उस टाइम हम एक्सरे कर लेते हैं। अगर तो उसमें भी abnormality आ गई है, as sometimes it can come that much early also, then you have to definitely admit and observe the child, and if asymptomatic, then discharge the child, let us say after 6 to 12 hours of observation, and follow up can be done of this child. अगर इस एक्सरे में कोई भी abnormality नहीं आई है, then next thing वही है कि आपने observe करना है for 6 hours at least, because as I told you, ज़रूरी नहीं है उस टाइम आए, 6 hours तक का टाइम लेता है for the chest x-ray to be full of abnormalities, number 1, number 2, even for the child to be symptomatic. आने वाले 6 घंटे में इस बच्चे को ARDS हो सकता है, interstitial pneumonitis हो सकता है, and of course because of kerosene per se chemical pneumonitis हो सकता है। तो इसलिए इस सब चीज़ों को डेवलप करने के लिए 6 घंटे का हम अपर लिमिट सोच करके we observe the child for 6 hours. So this is what we are going to do. And अगर बच्चा सिम्टोमेटिक आया है, let us say wheezing करके आया है, ऑल्टर्ड सेंसोरियम करके आया है, या टेकिपनिया करके आया है, जैसे इधर लिखा है, दैट मीन्स द सिम्टोमेटोलॉजी हैज ऑलरेडी प्रोग्रेस्ड, द इंजरी टू द लंग हैज ऑलरेडी टेकन प्लेस। तो उसमें आप क्या करोगे? सबसे पहले एडमिट करके हमने बच्चे को ऑक्सीजन शुरू करना है, IV फ्लूइड शुरू करने हैं, एंड बीटा एगोनिस्ट शुरू करते हैं, एंड देन वी मॉनिटर द रेस्पिरेटरी एंड न्यूरोलॉजिकल स्टेटस। नो स्टेरॉइड्स, or there is no role of steroids or any kind of prophylactic antibiotics. Please remember this. There's no role of any steroids or prophylactic antibiotics. Okay, what you have to do is just monitoring the respiratory and neurological status. Now the question comes कि मैम neurological status क्यों बोला आपने? So please remember, जो aromatic hydrocarbons होते हैं वो CNS पे ज़्यादा इफेक्ट करते हैं. So that is why the child will end up with drowsiness, and altered sensorium. So that is why, in general, hydrocarbon ingestion में we have to monitor the neurological and respiratory status. As far as the kerosene poisoning goes per se, kerosene poisoning का main effect तो respiratory tract पे होता है, and especially if you have tried to induce emesis or gastric lavage. So that has to be avoided, very very important. तो अगर हम अब क्वेश्चन देखें, क्वेश्चन था कि गैस्ट्रिक लवाज करेंगे, ऑब्वियसली नहीं करेंगे, आपको बता दिया. क्या हम ऑक्सीजन देंगे? क्या बच्चा हमारा सिम्टोमेटिक है? नहीं है, तो हम ऑक्सीजन भी नहीं देंगे. क्या हम आईवी स्टेरॉइड्स देंगे? आपको पता है आईवी स्टेरॉइड्स एंड आईवी एंटीबायोटिक्स का पर से केरोसिन पॉइजनिंग में कोई रोल नहीं है. हाँ, लेटर ऑन जाकर के जब बच्चे को एस्पिरेशन निमोनाइटिस हो जाता है, देन बिकॉज द चाइल्ड इज इन इंटेंसिव केयर यूनिट एंड मे कॉन्ट्रैक्ट हॉस्पिटल एक्वायर्ड इन्फेक्शंस, तब हम शुरू कर सकते हैं. बट पर से केरोसिन पॉइजनिंग एसोसिएटेड एस्पिरेशन निमोनाइटिस के लिए देयर इज नो रोल ऑफ IV एंटीबायोटिक्स एंड ऑफ कोर्स इंट्रावेनस स्टेरॉइड्स आल्सो. तो ये भी गलत है. तो हम क्या करेंगे? ऑफ कोर्स एक्सरे करेंगे, तभी इसमें रेडियोग्राफी लिखा हुआ है. तो यही है हमारा right choice baby, right? Radiography is the answer for this, right? Okay, चलो चलते हैं आगे. Next question करते हैं. The event related to vaccination which can be contraindication for the next vaccination of similar or identical type is. Now please remember over here कि किसी भी वैक्सीन के साथ अगर आपसे कॉन्ट्राइंडिकेशन पूछे जाए, आंख बंद करके आप एक सिंगल वर्ड बोलोगे एंड दैट इज एनाफाइलैक्सिस. किसी भी वैक्सीन के प्रीवियस डोज में अगर एनाफाइलैक्सिस हुआ है तो आप इस बच्चे को वो सिमिलर वैक्सीन का रिपीट डोज नहीं दोगे. दैट्स अ कॉन्ट्राइंडिकेशन. द चाइल्ड हैज हैड एनाफाइलैक्सिस टू सम कंपोनेंट ऑफ द वैक्सीन. सो दैट शुड बी वेरी क्लियर. एंड दिस एनाफाइलैक्सिस यूजुअली इज सीन विद वैक्सीन्स विच यूज एग प्रोटीन, जैसे कि येलो फीवर हो जाता है, येलो फीवर वैक्सीन हो सकती है, इन्फ्लुएंजा वैक्सीन हो सकती है. तो आपको ये भी पता होना चाहिए कि दो वैक्सीन्स जो कि स्पेशली अगर किसी इंसान को एग एलर्जी है तो दो वैक्सीन्स कॉन्ट्राइंडिकेटेड होती है. कौन सी? इन्फ्लुएंजा वैक्सीन आप नहीं देते एंड आप येलो फीवर वैक्सीन नहीं देते, क्योंकि दोनों में ही एग प्रोटीन यूज होता है. बट एनीवेज इफ यू सी एनाफाइलैक्सिस कौन कौन सी वैक्सीन से कॉमनली देखा जाता है, एनाफाइलैक्सिस इज कॉमनली सीन विद MMR वैक्सीन. इट इज अगेन वेरी कॉमनली सीन विद टेटनस वैक्सीन एंड ऑल्सो विद येलो फीवर वैक्सीन. येलो फीवर तो यू नो बिकॉज probably because of the egg component that can be contributory. तो anyways अगर कोई भी वैक्सीन है apart from these are the common vaccines causing anaphylaxis, पर अगर कोई भी वैक्सीन है जिसमें कि पहली डोज के साथ एनाफाइलैक्सिस हुआ है तो आप दोबारा वो नहीं करोगे. तो एक तो ये है. सेकेंड क्या कॉन्ट्राइंडिकेशन होती है जो कि सबको याद होनी चाहिए, एंड दैट इज एनकेफ्लोपैथी अकरिंग इन अ चाइल्ड हु हैज रिसीव्ड DPT इन द पास्ट 7 days. मतलब सेकेंड कॉन्ट्राइंडिकेशन जो होता है वो होता है एनकेफ्लोपैथी, राइट? और दैट ऑल्सो इन विद इन 7 days of pertussis or DPT vaccination, and we all know that this encephalopathy is because of the pertussis component. We know this, right? तो इसलिए ये दो मेन कॉन्ट्राइंडिकेशंस होते हैं जब अगर ये कोई वैक्सीन एसोसिएटेड इवेंट आ गया, ये दोनों, दैट मीन्स एनाफाइलैक्सिस या एनकेफ्लोपैथी फॉलोइंग pertussis vaccination occurring within 7 days of the vaccination, तो आप वापस रिपीट डोज ऑफ DPT एटलीस्ट इसमें नहीं देंगे, आप DT से कंप्लीट करेंगे सारी सीरीज. और अगर बच्चा 7 साल से ऊपर का है तब आप TD ही यूज करेंगे, क्योंकि P तो आपने करना ही नहीं है. ठीक है. सो आप हाउ डू यू कंप्लीट द दिस थिंग? सो प्लीज रिमेंबर 2 contraindications for any vaccine associated events. If I write it down over here, these are number 1 encephalopathy and second is anaphylaxis. And encephalopathy की भी एक एज टाइम ड्यूरेशन है, occurring within 7 days of pertussis vaccination. So then pertussis is contraindicated, ठीक है, ना कि पूरी DPT vaccine. If this happens, then you complete the dose with DT, right? That means diphtheria and tetanus component, or maybe with DT. So this is how you are supposed to do it. जो small DT आएगा वो usually more than 7 years में हम करते हैं, right? So ये आपको पता होना चाहिए. इसके साथ एक बहुत इंपॉर्टेंट क्वेश्चन जो कि आता है वो आता है जिसमें कि कंफ्यूजन आता है अक्सर बच्चों को, एंड दैट इज प्रिकॉशंस. प्रिकॉशंस कब लेने हैं? प्रिकॉशंस स्पेशली फॉलोइंग डीपीटी वैक्सीनेशन. क्या क्या इवेंट हो गए डीपीटी वैक्सीनेशन में विच विल वारंट प्रिकॉशंस? सबसे पहले क्या होगा? नंबर 1, अगर किसी बच्चे को फीवर मोर देन 40.8 डिग्री सेंटीग्रेड हुआ है विद इन 72 आवर्स ऑफ डीपीटी वैक्सीनेशन. So remember, this is not a contraindication for the repeat dose. Just you have to be cautious. You have to tell the parents and you can offer them कि next time आप ए सेलुलर कंपोनेंट वाला डीपीटी ले लो, होल सेल डीपीटी मत लो, क्योंकि ये सारे जो हम पढ़ रहे हैं ये होल सेल के लिए पढ़ रहे हैं. समझ गए? तो एक तो आ गया फीवर. सेकेंड चीज जो आपको पता होनी चाहिए दैट इज अगर किसी को हाइपोटेंसिव हाइपो रिस्पॉन्सिव एपिसोड हुआ है, अगेन इफ इट इज अकरिंग विद इन 72 आवर्स ऑफ डीपीटी वैक्सीनेशन, अगेन दिस इज not a contraindication for the future repeat doses, but of course we have to alert the parents कि आपके बच्चे को tendency है. If you want, we can give the vaccine as per the rules, the same whole cell vaccine, but acellular vaccine के लिए shift करना आपको option हर समय देना चाहिए. ठीक है? So ये second हो गया. थर्ड इसमें आता है अगर किसी को persistent inconsolable crying हो रही हो, persistent inconsolable crying for more than 3 hours. ठीक है? Please remember, for more than 3 hours अगर किसी को inconsolable crying हो रही हो, and that also again this इसके लिए time limit है within 48 hours of giving DPT vaccination. तो आप again you have to consider this as a precaution, and next time parents को you can offer the acellular component. And the fourth is if the seizures have occurred within 72 hours, within 72 hours of DPT vaccination, please remember again this is not a contraindication for the repeat DPT or wholesale DPT, but you can offer them acellular. So precautions आपको पता होने चाहिए. Absolute contraindications आपको बता दिए, that is encephalopathy and anaphylaxis. One more contraindication which we all should know is कि अगर किसी बच्चे को प्रोग्रेसिव न्यूरोलॉजिकल डिजीज है उसमें भी हम pertussis vaccination नहीं देंगे. We will not give the pertussis component. We will omit the pertussis component of the vaccine. Remember this. What about static neurological disease? Of course, diseases like CP, which is a static encephalopathy, उसमें आप pertussis बिल्कुल दे सकते हो. There is no contraindication. पर किसी को अगर progressive है तो आपने नहीं देनी है. क्या नहीं देनी है? pertussis component वाली वैक्सीन नहीं देनी है. ठीक है? एंड एनीवेज ये जो प्रोग्रेसिव न्यूरोलॉजिकल डिजीज वाला जो है, रिमेंबर दिस इज नॉट एन एब्सोल्यूट कॉन्ट्राइंडिकेशन, तभी मैंने वहां पे नहीं लिखा था. दिस इज कंसिडर्ड टू बी अ रिलेटिव कॉन्ट्राइंडिकेशन, बट यू शुड बी नोइंग अबाउट दिस. अनदर वेरी इंपॉर्टेंट कॉन्ट्राइंडिकेशन इन वैक्सीन जिसमें हम एक पर्टिकुलर वैक्सीन बिल्कुल नहीं देते हैं, एब्सोल्यूट कॉन्ट्राइंडिकेशन है, वो है कि अगर किसी बच्चे को SCID है, severe combined immunodeficiency. Remember, rotavirus is absolutely contraindicated. Remember this. So that is additional, some info for you जो कि आपको पता होना चाहिए, which is again your potential MCQ in the exams to come, right? Okay, now let us move on to the another this thing. Next question, again development question. I tell you, development and vaccination are the hot topics. So which one of the following can be used for the development screening for use in community to identify children aged 0 to 6 years with developmental delay? So if we see, just go through the options, revised Denver development screening test, which is very famously known as Denver 2. Then we have ASQ3, which is the ages and stages questionnaire, and that is known as ASQ3. Then we have the FATEX Baroda development screening test, and then we have the Trivandrum development screening test. Remember, all these four are the screening tests. There is no problem as far as if they are asking you for the screening test. Now they have asked you two more things along with just the screening test. They also want for the age group of 0 to 6 years, and very important thing also they have asked, which I will highlight later. First, let us see this. So let us start with the analysis of our options. First of all, remember one of the best development screening test, which is just a mirror image or the Indian adaptation of Bailey developmental scale, which has been used in the Western world, is the FATEX Baroda screening test, which was developed by Dr. Pramila Phatak. And this is applied up to the age of 30 months. Remember that. So 30 months तक के लिए होता है ये, and usually it requires, it is to be used by child psychologists and not by the pediatricians. So that is such an extensive, developmental screening test, and supposed to be one of the best screening tests to be developed till date in our country, right? So that is your FATEX Baroda screening test, and this is automatically out. This is not the answer because they have asked for age 0 to 6 years, and this can be only administered till the 30 months of age. So that is very clear with you. Now, if we move forward, let us come to the B option, that is the ages and stages questionnaire. What is this all about? As the name suggests, it is a kind of questionnaire which is meant for the parents, number one, and 30 items are there about the child's abilities, which the parents have to complete. Usually it takes around 10 to 15 minutes to complete, and around another 2 to 3 minutes to give scoring to this questionnaire. So that has been developed, and this is based on the age-based parent completed questionnaire. So that is what it is all about. And ages and stages, remember this questionnaire is usually administered from 1 month to 5.5 years. That means 5.5 साल तक. So ages and stages की age क्या हो गई? 1 month to 5.5 years. ठीक है. So again, this is not confirming with the क्वेश्चन आस्क्ड. हमें तो 0 to 6 years के लिए पूछा गया था, तो एजेस एंड स्टेजेस भी हमारा आउट हो गया. ठीक है. अब आते हैं नेक्स्ट ऑप्शन पे, एंड दैट इज योर रिवाइज्ड डेनवर डेवलपमेंटल स्क्रीनिंग टेस्ट, which is also known as Denver 2. So remember, this Denver 2 was revised in 1992. In fact, Denver development screening test was revised in 1992, and thereby it was then named as Denver 2, right? And it assesses child's development. We have to write because it's a very important test. So Denver 2, this was 1992. Easy to remember, 2 and 2. So 1992 it was revised. And this assesses child's development in 4 domains. And what are the 4 domains? So we know those 4 domains. They are gross motor. We know that. It is fine motor. And then we have the adaptive domain. And then we have the language, right? Language and personal and social behavior. Personal and social behavior. So these are the 4 domains in which the Denver 2 assesses the development of the child, and this is used to assess the development of children up till 6 years of age. So if we go back to our question, this this completely fits the description. Then what are we missing? Why this is not the answer? I'll still tell you that this Denver 2 is not the answer. I will still strike it off like this. Why? Because if you see at the 4th option, that is Trivandrum developmental screening test, even this was, this was revised in 2013. Remember that. And moreover, it has 51 items on which the child is assessed. And in this case also, the age group is 0 to 6 years to whom we can administer this test. And very importantly, this is the test which is very useful in the community to administer this test and to screen for developmental delay. So if you are asked specifically, it has been asked. I told you there's one thing which is asked in the question that will change the answer completely. So what was asked in the question was, कम्युनिटी में कौन सा टेस्ट हम अप्रोप्रिएट है, तो उसके लिए ट्रिवेंड्रम डेवलपमेंटल स्क्रीनिंग टेस्ट अप्रोप्रिएट है. रिमेंबर दिस. And this is used in the community for screening for developmental delay. An excellent tool which has been developed, and hence our option is, our correct answer is the Trivandrum Development Screening Test, that is the option D. Is that clear? Right. Okay, then let us move on to the next question, and the next question is, according to the WHO clinical criteria, which of the following clinical signs are indicative of severe pneumonia or very severe disease in children aged 2 months to 5 years? So we know the WHO clinical criteria. If you remember, the WHO clinical criteria classifies the disease either as cough and cold. So cough and cold, what will be? So there are 3 classifications for 2 months to 5 years. If I have to write it over here, let me make it like this. For 2 months to 5 years, any child coming with respiratory symptoms, either the child is classified just as cough or cold, that is, there is no involvement of the lower respiratory tract, or the child is classified as pneumonia, remember that, or the child is classified as severe pneumonia or very severe disease. Remember, there is no term as very severe pneumonia. It is just coined to, आपको confuse करने के लिए coin किया गया है. So it is either severe pneumonia or very severe disease. Now, what features, tell us कि बच्चा कौन सी category में है, because the treatment of these 3 categories is entirely different, poles apart from each other. You can very well, it is so obvious, you can very well assess it, because जब अगर cough cold है तो हम क्या करेंगे, हम कोई antibiotic भी नहीं देंगे, we'll just advise the mother to go for home care, right? And there is no antibiotic prescribed over here, and then you can follow up after 2 to 3 days, just to see whether if it is progressed further, pneumonia में तो नहीं तब्दील हो गया, then definitely we have to act, right? So ये तो कहानी हुई जब बच्चे को कफ या कोल्ड हम लेबल करते हैं. अब निमोनिया कब लेबल करते हैं? निमोनिया लेबल करते हैं either the child has fast breathing, remember this, or the child has chest indrawing, remember this, or both, right? अगर एक भी है तो भी चलेगा. So या तो फास्ट ब्रीदिंग है या चेस्ट इंड्रॉइंग है, तो इसमें हम क्या करते हैं, इसमें what do we do is, so we give oral antibiotic, usually it is the amoxicillin which is given, remember this, for 5 days, and we tell the mother to come back after 3 days. So again, this is a home based care. Apart from the difference is that this time we have given an antibiotic, remember that. Okay, what about the severe pneumonia? So what are the features of severe pneumonia? That's what was the question was all about, right? So if we see the severe pneumonia would be classified, or very severe disease would be classified when the child has the following features. What are the following features? Let us see that. So in severe pneumonia, the child will be unable to feed or drink, take water, right, or take feed. Then the child might be having convulsions, right? The child can be having lethargy, right? And the child can, even the presence of stridor in an, unusually calm child, even that is an ominous sign, and that places the child in the category of severe pneumonia or very severe disease. So stridor in a calm child, even that is not very good. And the 5th parameter which places the child in the category of very severe disease or severe pneumonia is if the child has severe malnutrition. So any of these if present, remember this child comes in the category of severe pneumonia or very severe disease. And what are we supposed to do? What are we supposed to do is that we have to refer the child urgently to a higher center. Important is this. And secondly, that we have to, before referring, remember to give first dose of IV antibiotics. So first dose of, usually they say give IV antibiotics. Now that can be Ampigenta, that can be Amoxi, right? If the child is not able to take orally, how will you give Amoxi? So Ampigenta usually are the preferred antibiotics which are to be given as the first dose before referring the child to the higher center, right? Now coming back to our question. So our question was कि severe disease, very severe disease या severe pneumonia में क्या क्या symptoms होते हैं या क्या क्या इसके signs होते हैं which places the child in very severe disease or severe pneumonia. Let us see that. So convulsions, of course I just told you, lower chest indrawing, वो तो आपको पता है कि lower chest indrawing जो है वो तो सिर्फ pneumonia में बच्चे को place करेगा, ठीक है, कन्वल्जन्स बच्चे को वेरी सीवियर डिजीज या सीवियर निमोनिया में करेगा। सो सेकंड ऑप्शन तो नहीं है, ठीक है। इनेबिलिटी टू फीड, यस ये भी है। स्ट्राइडर आई टोल्ड यू ये भी है। तो आंसर हुआ 1, 3 एंड 4 एंड 1, 3 एंड 4 हमारा है ऑप्शन सी में। तो ये हमारा करेक्ट आंसर होगा, राइट। ओके, अब चलते हैं आगे। लेट अस कम टू द नेक्स्ट क्वेश्चन एंड दैट इज 11 month old unimmunized child. Again one question from immunization. So immunization development तो should be very thorough. So अनइम्यूनाइज्ड बच्चा आया है आपके पास, कितना बड़ा, 11 month old बड़ा। विच वैक्सीन्स वुड बी गिवन इन दिस फर्स्ट विजिट, ठीक है। सो इसमें हमारे पास कैचअप वैक्सीनेशन के लिए कुछ रूल्स दिए गए हैं। इंडियन अकेडमी ऑफ पीडियाट्रिक्स ने हमको रूल्स दिए हैं, ठीक है। वेरी इंपॉर्टेंटली बीसीजी तो हमने जरूर करनी है। अकॉर्डिंग टू WHO, अकॉर्डिंग टू द नेशनल इम्यूनाइजेशन पॉलिसी, बीसीजी का कैचअप वैक्सीनेशन हम 1 साल तक करते हैं, जबकि इंडियन अकेडमी ऑफ पीडियाट्रिक्स के हिसाब से हम 5 साल तक करते हैं। बट एनीवेज अभी तो कोई विडंबना नहीं है, देयर इज नो कंट्रोवर्सी बिकॉज दे हैव आस्क्ड फॉर अ 11 month old चाइल्ड। तो आप सबसे पहले क्या करोगे, सबसे पहले तो इसको बीसीजी तो दोगे वेरी इंपॉर्टेंटली। सेकेंडली आप क्या दोगे, ओपीवी दोगे और डीपीटी वाली वैक्सीन दोगे। होलसेल दे सकते हो, ए सेलुलर दे सकते हो, जो भी ऑप्शन लेना चाहे वो। एंड ऑफ कोर्स हेपेटाइटिस बी। तो ये 4 वैक्सीन आपने देनी ही देनी है। सो ओपीवी, देन यू हैव द डीपीटी दैट इज होलसेल, और डीटीएपी विच इज द ए सेलुलर, एंड द फोर्थ इज योर हेपेटाइटिस बी। सो ये 4 वैक्सीन आप देते हो जब बच्चा आपके पास पहली बार 11 महीने पे आता है, राइट। अब सेकेंड विजिट आफ्टर 1 month क्या दोगे, तो आफ्टर 1 month आप क्या दोगे, अगर ये एट टाइम ऑफ प्रेजेंटेशन है, ठीक है। आफ्टर 1 month क्या देंगे ये भी हम बता देते हैं। तो आफ्टर 1 month समझ लो आपसे पूछे कि सेकेंड टाइम आया है तो आप क्या दोगे, सेम क्वेश्चन बट अ ट्विस्ट इन द क्वेश्चन। तो अगेन आप डीपीटी, अब तो बीसीजी तो रिपीट करोगे नहीं क्योंकि बीसीजी तो एक बार मिलनी है, वो तो काम खत्म हो गया, राइट। तो क्या हम ओपीवी देंगे, तो ओपीवी तो देंगे, तो ओपीवी पहले लिख देते हैं। फिर क्या हम डीपीटी देंगे, तो डीपीटी तो देना है, कम से कम 2 डोजेस तो जानी चाहिए, राइट। अगर आप जब कैचअप वैक्सीनेशन डीपीटी का करते हो, रिमेंबर डीपीटी का जो कैचअप वैक्सीनेशन होता है, ठीक है, उसमें स्केड्यूल चलता है बिल्कुल आपके हेपेटाइटिस बी की तरह, 0, 1 एंड 6, राइट। तो ये 0 डोज हो गया, ये 0 हो गया, ये 1 आफ्टर 1 month हो गया। तो आप डीपीटी भी दोगे या डीटीएपी, जो भी आपने सीरीज चालू कर रखी है, एंड ऑफ कोर्स हेपेटाइटिस बी भी दोगे, क्योंकि हेपेटाइटिस बी की भी यही वैक्सीनेशन स्केड्यूल होता है, ठीक है, राइट। तो ये आफ्टर 1 month दोगे। फिर आफ्टर 2 months क्या दोगे, अगर हमने आफ्टर 2 months करना है, बच्चा अब आपके पास आता है कि बच्चा पहले आया आपको डे 0 पे और फिर 1 month के बाद आया और उसके बाद अब 2 months पे आया है। 2 months इज द स्टार्ट ऑफ वैक्सीनेशन है। 11 महीने का बच्चा अब हमारा कितने का हो गया, 13 महीने का हो गया। अब क्या दोगे इसको, तो जब आफ्टर 2 months आता है तो एक तो ओपीवी दोगे, दूसरा आप एमएमआर दोगे, ठीक है। एमएमआर प्रेफर करोगे, अगर एमएमआर नहीं मिल रही तो आप मीजल्स दे दो, कोई बात नहीं, ठीक है। एटलीस्ट मीजल्स जरूर दो, क्योंकि बच्चा 13 महीने का हो गया एंड अब तक तो जो मैटरनल प्रोटेक्टिव एंटीबॉडीज होंगी वो तो बिल्कुल ही खत्म हो गई होंगी, राइट। तो ये दे दो। टाइफॉइड दोगे इसको, ठीक है। तो ये आप दोगे आफ्टर 2 months। अब इसमें सबसे इंपॉर्टेंट चीज ये आती है कि अगर बच्चा आपके पास आफ्टर 6 months आए, ठीक है, तो क्या दोगे, क्योंकि आपको पता है कि आफ्टर 6 months में आपका 1 डोज हेपेटाइटिस बी का भी जाएगा 016 के हिसाब से, और डीपीटी का भी जाएगा। तो डीपीटी अगर मैं लिखूं दैट इज होलसेल या डीटीएपी, तो आफ्टर 6 months ये होता है। तो आपको ये चारों चीजें पता होनी चाहिए, बहुत ही लॉजिकल है, रटने की जरूरत नहीं है। बस फर्स्ट जो 0 डोज है वो आपको पता होनी चाहिए कि 0 टाइम दैट इज फर्स्ट टाइम जब बच्चा आता है तो आपने बच्चे को 4 वैक्सीन देनी है। 4 वैक्सीन में से 2 तो बर्थ वैक्सीन है, दैट इज बीसीजी एंड ओपीवी, वो आप समझ लो, एंड फिर डीपीटी और हेपेटाइटिस बी, एंड देन उसका तो 0-1 से स्केड्यूल चलेगा, ठीक है। इंपॉर्टेंट चीज है जो आफ्टर 2 months है वो थोड़ी सी हटके है, वो आपको याद होनी चाहिए, राइट। तो इसमें क्या हो गया आंसर, इसमें हमारा फर्स्ट ऑप्शन हो गया, ठीक है, क्लियर हो गया। चलो अब क्या देखते हैं, नेक्स्ट क्वेश्चन इज फॉर डेवलपमेंट असेसमेंट ऑफ अ बेबी ग्रास्प इज बेस्ट असेस्ड बाय ऑफरिंग द चाइल्ड। हलवा क्वेश्चन है, यूं की यूं लाइन उठ के आ गई है हमारे स्टैंडर्ड टेक्स्ट बुक से। सो द आंसर इज अ रेड क्यूब, तो ये आपको पता होना चाहिए। सो रेड क्यूब, दिस इज द करेक्ट वे ऑफ असेसिंग द ग्रास्प, आपको पता होना चाहिए ग्रास्प कई सारे स्टेजेस से गुजरता है। पहले तो 5 मंथ्स पे बच्चा जस्ट रेक करेगा, रेक का मतलब यहाँ पे पैलेट पड़ा हुआ है तो ये आपकी उंगलियां बस ऐसे आकर के उसके अराउंड सराउंड करेगी, ठीक है। फिर आपके 6 to 7 मंथ्स पे पहले अल्नर ग्रास्प आता है, ठीक है। फिर उसके बाद रेडियल 7 to 8 मंथ्स पे रेडियल ग्रास्प आएगा, एंड देन रेडियल ग्रास्प विल गो ऑन टू डेवलप पामर ग्रास्प, ठीक है। एंड देन उसके बाद 9 मंथ्स पे अभी अभी हमने डिस्कस किया इमेच्योर पिंसर ग्रास्प आता है, ठीक है, जो कि मेच्योर पिंसर ग्रास्प कब हो जाता है, 12 मंथ्स पे जाके ये मेच्योर पिंसर ग्रास्प आता है, ठीक है। तो इसमें रेड क्यूब आप दोगे तो उसमें आप अल्नर रेडियल सब कुछ आपको पता पड़ जाएगा, सो दैट यू शुड नो, ठीक है। Then in case of a next question is in case of a child with an acute poisoning by ingestion, activated charcoal may be used in one of the following situations. अब ये थोड़ा सा ट्रिकी क्वेश्चन था क्योंकि आपको पता होना चाहिए कि एक्टिवेटेड चारकोल is considered to be a potentially very useful method of GI decontamination. ये तो हमको पता है, शुरू से ही हमको याद करवाया गया है, रटवाया गया है कि जी चारकोल दे दो, ठीक है। And remember it is most likely to be effective if it is given within 1 hour of toxin ingestion. But what is more effective is इसकी डोज भी पता होनी चाहिए, बहुत सिंपल सी डोज होती है, 1 ग्राम पर kg के हिसाब से हम देते हैं, ठीक है। अब इसमें जो चीजें आपको पता होनी चाहिए वो होती है 3 चीजें। सबसे पहले सिंपल चीज आपको बताते हैं, a patent and a stable airway should always be there before administering charcoal. Always remember this. ठीक है, so patent and stable airway need to be there. ठीक है, before administering charcoal. Secondly, जो आपको बात पता होनी चाहिए वो ये है the contraindications, जिसमें तो बिल्कुल ही नहीं देना। contraindications मतलब ड्रग्स या टॉक्सिन्स नहीं जिसमें आपने नहीं देना, पर अगर किसी बच्चे में एग्जिस्टिंग या अंडरलाइंग ये प्रॉब्लम्स हैं तो उसमें चारकोल हम नहीं देते हैं। कॉमन सेंस लगाइए जी, किसमें नहीं देंगे, जिसमें आपकी आंतें नहीं चल रही हैं, आपकी इंटेस्टाइनल मोटिलिटी नहीं है। तो किसमें होती है, जिसमें इंटेस्टाइनल मोटिलिटी गायब होती है, एक तो होगा आइलियस, राइट, कॉमन सेंस लगाइए, आइलियस होगा, ठीक है। और क्या होगा, इंटेस्टाइनल ऑब्स्ट्रक्शन होगा, पेरिटोनाइटिस होगा, एंड ऑफ कोर्स एक और चीज होगी जो भी हम बताते हैं। सो आइलियस, पेरिटोनाइटिस ये लिख लेते हैं, intestinal obstruction, तो इन सब में आपके there is the decreased intestinal motility and then therefore charcoal देना is a very very bad idea, ठीक है। So intestinal motility, intestinal obstruction. And the fourth contraindication, very very important, is if the child has ingested any corrosives, then also you do not give this thing charcoal, ठीक है। अब इसमें क्वेश्चन जो आपसे पूछा गया है कि इनमें से किस में नहीं देंगे, तो ये तो पक्का हो गया कि कोरोसिव में नहीं देंगे। अब हम वापस फंस गए, बाकी 3 में देना है कि नहीं देना है, ठीक है। तो यस, देयर इज अ होल लिस्ट किस में नहीं देते हैं। एक निमोनिक है, याद करने की कोशिश कर लो, आपके लिए अच्छा होगा, ठीक है। सो इसका हिज माइका, क्योंकि हम पॉइजनिंग की बात कर रहे हैं तो एक दिमाग में आएगा कि माइका पी लो, ठीक है, पी लो, पीकर या पी लो, माइका पी लो, मस्त एहसास आता है, ठीक है। मस्त इज डबल एम के साथ, ठीक है। जो भी कैपिटल लेटर्स में है उससे हमारा निमोनिक बनेगा। सो माइका पी लो, मस्त एहसास। अब इसमें क्या क्या आता है, एम से क्या क्या आता है, वेरी वेरी इंपॉर्टेंट इज, सबसे इंपॉर्टेंट मिनरल एसिड्स और बेसिस बताया, कोरोसिव में नहीं देते, तो वो तो हमने कॉन्ट्राइंडिकेशन में जी याद कर लिया। सेकंड वेरी इंपॉर्टेंट, आयरन में नहीं देते, ठीक है। तीसरा किस में नहीं देते, माइका का फुल फॉर्म, साइनाइड में नहीं देते। चौथा अल्कोहल में नहीं देते, ठीक है। तो ये तो आपका माइका हो गया, रिमेंबर दिस इज माइका, ठीक है। मिनरल एसिड्स एंड बेसिस, आई से आयरन, सी से साइनाइड एंड ए से अल्कोहल, सो माइका। अब पी से क्या आएगा, सो पी से आएगा पेस्टिसाइड्स, पी लो, सो पेस्टिसाइड्स। एल से क्या आएगा, एल से आएगा लिथियम, ठीक है। मस्त एहसास, मस्त एहसास में 2 एम है, ठीक है। सो मोस्ट ऑफ दी वॉट, दोनों चीजें मोस्ट ऑफ दी के नाम से है तभी हमने वो कर लिया। सो मोस्ट ऑफ दी वाटर सॉल्यूबल कंपाउंड्स इंपॉर्टेंट, and most of the solvents, इन दोनों में आप नहीं दोगे। हम ये सारी लिस्ट बना रहे हैं जिसमें हमने चारकोल नहीं देना है, आपसे ये क्वेश्चन पूछा गया है, ठीक है। सो 7, 8 मस्त AST से तो कुछ भी नहीं है, एहसास, E से कुछ रह गया, E से है इलेक्ट्रोलाइट्स, कॉमन इलेक्ट्रोलाइट्स। सो ये इंपॉर्टेंट है, रिमेंबर दीज आर द things, these are the ingestion. If happens of any of them, then remember what is not to be given. Activated charcoal is not to be given. Now the question comes, what is activated charcoal? Basically we heat the charcoal, तो उससे क्या होता है, उसके pores बढ़ जाते हैं और porous होने की वजह से उसका surface area of absorbing A with D for दिया, D for Daman and D for Delhi. So absorbing the power or the capability of absorbing the toxins वो बढ़ जाती है, right? तो activated charcoal उसको कहते हैं। इन सब चीजों में activated charcoal is not to be given, ठीक है। इसका एक निमोनिक हमने बनाया है, माइका पीलो मस्त एहसास, राइट? सो ये आपको पता होना चाहिए वेरी इंपॉर्टेंटली। तो अब हम इसमें क्वेश्चन कर लेते हैं। तो आपको पता है पी लो में L में लिथियम था, तो इसमें भी नहीं देंगे। देन आयरन में, माइका में M से, तो आप I से तो हमारा आयरन था, तो आयरन भी नहीं देंगे। तो हमारा क्या सही आंसर आ गया? इसमें हमारा सही आंसर आ गया एंटी एपिलेप्टिक इंजेक्शन में हम दे देंगे। समझ गए? तो ये हो गया क्वेश्चन। नेक्स्ट क्वेश्चन करते हैं अब, विच ऑफ द फॉलोइंग जेनेटिक कॉजेज आर कॉमनली विद ऑटिस्टिक या ऑटिज्म स्पेक्ट्रम डिसऑर्डर्स, राइट? तो ये तो हमको याद रखना है, कुछ डिसऑर्डर्स विच आर विद ऑटिज्म, ठीक है। ऑटिज्म में हमको पता है देयर इज अ प्रॉब्लम विद द सोशल इंटरेक्शन, देयर इज अ लैंग्वेज डिले, ठीक है, ये सब का होता है। एंड यूजुअली दीज फीचर्स आर सीन बिफोर 3 years ऑफ एज। नाउ कौन से सिंड्रोम्स, जेनेटिक प्रीडिस्पोजिशन कौन से सिंड्रोम्स के साथ आता है? सो यस, एंजलमैन में होता है ऑटिज्म होने का चांसेस, फ्रेजाइल एक्स में भी होता है, ट्यूबरस स्क्लेरोसिस में भी होता है। इसके अलावा और किस में होता है ये भी हमको पता होना चाहिए। तो डाउन्स में भी होता है, रिमेंबर डाउन्स में भी होता है। देन देयर इज नोन एज टिमथी सिंड्रोम में भी होता है। फिर एक कहते हैं जॉबर्ट सिंड्रोम, जिसमें अगर जॉबर्ट सिंड्रोम आपको याद हो, क्योंकि आप लोगों को सारे सब्जेक्ट्स पढ़ने हैं, इसमें आता है मोलार टूथ साइन ऑन MRI, राइट, विच इज अ वेरी वेरी इंपॉर्टेंट डायग्नोस्टिक साइन फॉर जॉबर्ट सिंड्रोम। तो इसमें भी ऑटिज्म होने के चांसेस होते हैं। तो ये सारे कॉमन होते हैं जेनेटिक कॉजेज जो आपको याद होना चाहिए, नेमली टू कंप्लीट द लिस्ट, डाउन सिंड्रोम, टिमथी सिंड्रोम एंड जॉबर्ट सिंड्रोम। ओके, सो हमारा आंसर क्या आएगा? उसमें पूछा है कि किस में होते हैं, तो 1, 2 एंड 3 में होते हैं, तो हमारा करेक्ट आंसर आ जाएगा 1, 2 एंड 3 इसमें होता है। विलियम सिंड्रोम में ऑटिज्म का कोई रिस्क नहीं देखा गया है, ठीक है। अब नेक्स्ट क्वेश्चन इज, टू रिड्यूस द रिस्क ऑफ न्यूरल ट्यूब डिफेक्ट्स इन द बेबी, विच आर द फॉलोइंग आर रिकमेंडेड? Folate supplementation from 1 month before conception to 3 months after, folate supplements from confirmation of pregnancy to the end of the first trimester, zinc supplements from 1 month before conception to 3 months after, and zinc supplements from confirmation of pregnancy to the end of the first trimester. देखो, अगर आपको चूज करना है between zinc and folate, definitely this is going to be folate. जिंक भी बोला जाता है, ठीक है, इट इज गुड फॉर सप्लीमेंटेशन में। जिंक डेफिशिएंसी इज एसोसिएटेड विद न्यूरल ट्यूब डिफेक्ट्स, बट इफ देयर इज अ कॉन्टेस्ट बिटवीन जिंक एंड फोलेट, इट हैज टू बी फोलेट। अब फोलेट सप्लीमेंटेशन कैसे देते हैं? सो फोलेट सप्लीमेंटेशन आपका क्या ये आंसर आएगा, क्या ए ऑप्शन आएगा? रिमेंबर, ए ऑप्शन तब वैलिड होगा अगर किसी मदर को प्रीवियस चाइल्ड विद न्यूरल ट्यूब डिफेक्ट की हिस्ट्री है। तो ऐसे में आप मदर को 1 month बिफोर कंसेप्शन चालू करते हैं, एंड देन दैट हैज टू बी कंटिन्यू टिल एटलीस्ट 3 months ऑफ फर्स्ट 3 months ऑफ प्रेगनेंसी, बिकॉज दैट इज द टाइम व्हेन योर न्यूरल ट्यूब इज डेवलपिंग, राइट? एंड द डोज इज ऑल्सो डिफरेंट, रिमेंबर दिस। एक तो आपने जल्दी चालू किया, प्लस डोज भी आप 10 times दे देते हो। यहाँ पे यूजुअल प्रेगनेंसी में आप 0.4 mg देते हो, यहाँ पे आप 4 mg पर डे देते हो। समझ में आ गया? तो एक तो डोज भी 10 times हो गई, प्लस आपने शुरू भी जल्दी कर दिया, पर वो आप तब करोगे जब प्रीवियस सिब है विद न्यूरल ट्यूब डिफेक्ट की हिस्ट्री है। अगर कोई मदर है जिसका प्रीवियस बच्चा या तो सही है या खुद ही प्राइमरी ग्रेविडा है, तो ऐसे में आप यूजुअली कंफर्मेशन ऑफ प्रेगनेंसी टू द एंड ऑफ द फर्स्ट ट्राइमेस्टर तक देते हो। इज दैट क्लियर? ठीक है, ओके। नेक्स्ट हम आते हैं, वैक्सीन एसोसिएटेड पोलियोमाइलाइटिस चीफली सीन विद विच ऑफ द फॉलोइंग स्ट्रेन्स ऑफ ओरल पोलियो वायरस? हमको पता है OPV के 1, 2 एंड 3 स्ट्रेन होते हैं, ठीक है। टाइप 2 जो था, ठीक है, टाइप 2 की जो इम्यूनोजेनिसिटी थी वो बहुत बढ़िया थी, और बहुत बढ़िया होने की वजह से जो वाइल्ड पोलियो वायरस हो गया उसका तो संहार हो गया, ठीक है, वाइल्ड पोलियो वायरस गायब ही हो गया, क्योंकि जो हमने टाइप 2 ओपीवी जो बनाई थी उसकी इम्यूनोजेनिसिटी अच्छे होने के कारण WPV मतलब WPV टाइप 2 वाला वाइल्ड पोलियो वायरस टाइप 2 स्ट्रेन वाला इस दुनिया से गायब हो गया। तो अब तो टाइप 2 आता ही नहीं है, आपको पता होना चाहिए। बाइवेलेंट सिर्फ टाइप 1 और टाइप 3 इंक्लूडेड होते हैं आपके ओपीवी में। आई होप यू नो दिस, राइट। अब क्वेश्चन आता है कि वैप, अगर आप वैप देखो, वैक्सीन एसोसिएटेड पोलियोमाइलाइटिस, ठीक है, तो इसमें क्या होता है कि ये जब हम ओरल पोलियो वैक्सीन देते हैं उसमें लाइव अटेन्यूएटेड वायरस होता है जो कि हमारे फेरिंग्स एज वेल एज जीआई ट्रैक्ट में मल्टीप्लाई करता है। कभी कभी मल्टीप्लिकेशन होते होते, ठीक है, एंड उस मल्टीप्लिकेशन होते होते क्या हो जाता है कि ह्यूमोरल एंड सेलुलर रिस्पॉन्स दोनों को ये स्टिमुलेट करता है और हमारी बॉडी में अच्छी खासी इम्यूनिटी आ जाती है अगेंस्ट द वाइल्ड पोलियो वायरस। वाइल्ड पोलियो वायरस इज द डिजीज कॉजिंग वायरस, वैक्सीन स्ट्रेन इज द वैक्सीन अटेन्युएटेड स्ट्रेन। तो वैक्सीन अटेन्युएटेड स्ट्रेन ने मल्टीप्लाई किया, उसकी वजह से ह्यूमोरल और सेलुलर इम्यूनिटी आ गई एंड उसकी वजह से अब हमारी बॉडी सक्षम हो जाती है टू टैकल द वाइल्ड पोलियो वायरस विच इज द डिजीज कॉजिंग वायरस, राइट। ये समझ आ गया। अब प्रॉब्लम क्या होती है कि ये मल्टीप्लिकेशन के दौरान, जैसे कि मैं बता रही थी, कभी कभी मल्टीप्लाई होते होते वो ह्यूमोरल सेलुलर इम्यूनिटी को तो स्टिमुलेट करे ना करे, बट कभी कभी मल्टीप्लाई होते होते दैट इट gets converted into a neurovirulent strain, and this neurovirulent strain goes and attacks the spinal cord, the anterior horn cells, and इस बच्चे को वैक्सीन एसोसिएटेड पैरालिटिक पोलियोमाइलाइटिस हो जाता है, ठीक है। अब कॉमन स्ट्रेन्स कौन सा रहा, देखो पहले तो बच्चों बोला जाता था टाइप 2 और टाइप 3 दोनों है, ठीक है। उसमें भी ये हम लिखते थे कि जो टाइप 3 है वो तो रिसिपिएंट्स को करेगा, ठीक है, रिसिपिएंट्स को वैप करेगा, और जो टाइप 2 है वो कॉन्टैक्ट्स, मतलब अगर मैंने टाइप 2 वाली ओपीवी ली है तो मेरे कॉन्टैक्ट में जो आएगा उसको वैप अगर होगा तो टाइप 2 कॉन्टैक्ट वाले में करवाता है, जिसको मिलती है उसको नहीं करवाता, ठीक है। तो ये बोला जाता था, ठीक है। बट अब क्योंकि टाइप 2 गायब हो गया है फ्रॉम द सिस्टम, दैट इज है नहीं, क्योंकि मैंने बताया था आपका इम्यूनोजेनिसिटी बहुत हाई थी, तो जल्दी जल्दी वाइल्ड पोलियो वायरस गायब हो गया। तो इसलिए अब आपका आंसर सिर्फ और सिर्फ टाइप 3 होना चाहिए। टाइप 1 तो कभी पिक्चर में नहीं आया इन कॉजिंग वैप, रिमेंबर। सो आंसर विल बी ओपीवी टाइप 3 ओनली। इज दैट क्लियर? ठीक है, चलो आगे चलते हैं। नेक्स्ट क्वेश्चन, विच वन ऑफ द फॉलोइंग इज कैटेगराइज्ड एज अ स्पेसिफिक लर्निंग डिसेबिलिटी। तो लर्निंग डिसेबिलिटी में हमारे कई सारे टर्म्स आते हैं जो हमें पता होने चाहिए। कुछ तो हमको वैसे ही पता है, ADHD आता है, दैट ठीक है। और क्या आता है, डिसकैलकुलिया आता है। डिसकैलकुलिया मतलब नाम से पता पड़ रहा है भाई बच्चे को कैलकुलेशन में प्रॉब्लम होगी, तो मतलब मैथ्स रिलेटेड प्रॉब्लम होगी, मैथ्स एंड कैलकुलेशन रिलेटेड प्रॉब्लम होगी, ठीक है। फिर इसमें आता है डिसग्राफिया। डिसग्राफिया क्या होता है कि बच्चे को कहीं ना कहीं हैंड राइटिंग लिखने में, ठीक है, कुछ लिखने में प्रॉब्लम होगी, तो हैंड राइटिंग में प्रॉब्लम होगी तो उसको हम कहते हैं डिस्ग्राफिया, ठीक है। हैंड राइटिंग की एबिलिटी एंड फाइन मोटर स्किल्स दोनों इफेक्ट होती है इसमें, ठीक है। तो फाइन मोटर स्किल्स एंड हैंड राइटिंग डिसेबिलिटी। और क्या आता है, हम सबने देखी होगी तारे जमीन पर, एंड दैट इज डिसलेक्सिया। डिसलेक्सिया में यूजुअली क्या होता है, रीडिंग डिसेबिलिटी आती है। उसमें तो उन्होंने राइटिंग भी वैसे बोली थी, बट यूजुअली इसमें आती है रीडिंग डिसेबिलिटी, ठीक है। सो द चाइल्ड इज नॉट एबल टू रीड प्रॉपर्ली, सो रीडिंग डिसेबिलिटी आती है। एंड स्पेसिफिक लैंग्वेज बेस्ड प्रोसेसिंग स्किल्स भी आते हैं, प्रॉब्लम होती है, ठीक है। बट एनीवेज आप रीडिंग डिसेबिलिटी याद रखो, दैट इज डिसलेक्सिया। देन व्हाट, वन मोर थिंग व्हिच इज left is dyspraxia. What is dyspraxia? Can anybody tell me? Yes. So dyspraxia में क्या होता है कि it is a disorder in which there is a problem with the movement, coordination, language and speech. ठीक है, तो अगर हम लिखें इसको, the problem is with the movement, dyspraxia है ना, movement, coordination, language and speech. तो ये सब तरह तरह के डिसेबिलिटीज, लर्निंग डिसेबिलिटीज हैं जो आपको पता होने चाहिए, इंक्लूडिंग ADHD ऑल्सो, ठीक है। अब यहाँ पे देखते हैं कि हमारा कौन सा इसमें मैच हो रहा है। तो इसमें हमारा मैच हो रहा है, अगर आप देखो, डिस्ग्राफिया मैच हो रहा है, राइट, द हैंड राइटिंग वाली एबिलिटी। तो ये आपका आंसर हो जाएगा, डिस्ग्राफिया इज द करेक्ट आंसर, राइट। ओके, देन अब नेक्स्ट क्वेश्चन पे चलते हैं. अ बेबी इज डिलीवर्ड एट 34 वीक्स gestation एंड फाउंड टू बी एपनिक एट बर्थ. सो वन टॉपिक फ्रॉम न्यूरोलॉजी जो कि बहुत इंपॉर्टेंट है, आपके पास टाइम नहीं है पर आप कुछ करना चाहते हो. इनफैक्ट 2 टॉपिक्स आई वुड रिकमेंड. वन इज न्यूट्रल रिससिटेशन एंड द अदर इज इंट्रायूट्राइन इन्फेक्शंस. तो ये दोनों आपके बड़े थरो होने चाहिए. बहुत कॉमनली क्वेश्चंस न्यूरोलॉजी में से पूछे जाते हैं. सो ये हमारे न्यूट्रल रिससिटेशन पे आ गए कि 34 वीक्स gestation का बच्चा हुआ है, एपनिक है, हमने इनिशियल स्टेप्स तो परफॉर्म कर लिए. अब क्या करें जी? तो इनिशियल स्टेप्स क्या होते हैं हमारे? इनिशियल स्टेप्स होते हैं जब हम बच्चे को एक प्री वार्म टॉवल में लेते हैं, उसको रेडिएंट वार्मर के नीचे ले जाते हैं, फिर उसको सक्शन करते हैं, ठीक है, उसका माउथ रीपोजिशन करते हैं, उसको ड्राई करते हैं टॉवल से, ठीक है. तो ये सारे जो स्टेप्स हैं ये वाले, ठीक है, एयरवे देखते हैं उसका क्लियर है कि नहीं, इन सबको हम कहते हैं, अगर हम ऐसे करें, इन सबको हम कहते हैं इनिशियल स्टेप्स. तो हमने इस बच्चे के साथ इनिशियल स्टेप्स तो कर लिए, बट बच्चा तो फिर भी एपनिक है. तो हम क्या करें? तो देखो जी, हार्ट रेट लेस देन 100, एपनी और गैस्पिंग. तो हम क्या करेंगे? ऑब्वियसली वी विल स्टार्ट विद पॉजिटिव प्रेशर वेंटिलेशन. तो पॉजिटिव प्रेशर वेंटिलेशन करेंगे. तो ये तो बहुत सिंपल क्वेश्चन हो गया. नहीं, ये सिंपल क्वेश्चन तो नहीं है. क्यों नहीं है सिंपल क्वेश्चन? क्योंकि अगर आप देखो, इसलिए सिंपल क्वेश्चन नहीं है क्योंकि देखो आपके 2 ऑप्शंस हैं पॉजिटिव प्रेशर वेंटिलेशन के. तो यहाँ पे तो हम चकमा खा गए. अब हम क्या करें? तो हमको पढ़ाया गया है कि अगर तो ये बच्चा टर्म जेस्टेशन का होता तो हम 21% ऑक्सीजन से ही शुरू करते बैग एंड मास्क वेंटिलेशन या पॉजिटिव प्रेशर वेंटिलेशन. और अगर ये बच्चा प्री टर्म है, जो कि ये है, लेस देन 37 वीक्स है, तो ये प्री टर्म बच्चा है, ये हमको पता है. तो इसमें हम यूज करते हैं एनीवेयर बिटवीन 21 to 30% ऑफ ऑक्सीजन विद बैग एंड मास्क वेंटिलेशन. ठीक है, प्लीज रिमेंबर बैग एंड मास्क वेंटिलेशन एंड पॉजिटिव प्रेशर वेंटिलेशन आर सिनोनिमस विद ईच अदर. दिस शुड बी वेरी क्लियर टू यू. सो इसमें आंसर क्या हो जाएगा? इसमें आंसर आ जाएगा कि हम 30% ऑक्सीजन से शुरू करेंगे. 100% से करेंगे? नहीं जी, 100% से हम नहीं करते. पर यहाँ पे एक कैच है जो आपको पता होना चाहिए. किसी भी टाइम जब आप रिससिटेशन कर रहे हो, द मोमेंट यू स्टार्ट विथ चेस्ट कंप्रेशंस, अब यू नो कि चेस्ट कंप्रेशंस आप कभी आइसोलेशन में नहीं दोगे. चेस्ट कंप्रेशन विद बैग एंड मास्क, या इनफैक्ट इट इज बेटर टू राइट पॉजिटिव प्रेशर वेंटिलेशन, क्योंकि हो सकता है आपने बच्चे को ट्यूब एंडोट्रेकियल इंट्यूबेशन कर दिया. ठीक है, तो चेस्ट कंप्रेशन कभी आप अकेले में तो देते नहीं हो. चेस्ट कंप्रेशन के साथ आप क्या देते हो? बैग एंड ट्यूब वेंटिलेशन करते हो. ठीक है, तो बैग एंड ट्यूब वेंटिलेशन या पॉजिटिव प्रेशर वेंटिलेशन जब भी देते हो, तब पॉजिटिव प्रेशर वेंटिलेशन में आपकी ऑक्सीजन आप बढ़ा के 100% कर देते हो. तो रिमेंबर, 100% ऑक्सीजन कब आएगी? जब बच्चे को चेस्ट कंप्रेशन विद पीपीवी चालू होगा. नहीं तो आप यहाँ तो 21% दोगे टर्म बच्चे के लिए एंड प्री टर्म के लिए 21 to 30% दोगे. इज दैट क्लियर? ठीक है, सो नेक्स्ट क्वेश्चन करते हैं. अ चाइल्ड रिक्वायर्स डिटेल्ड डेवलपमेंटल इवैल्यूएशन इफ द डेवलपमेंटल कोशेंट इज बिलो. ठीक है, ये आपसे पूछा गया है कि भाई डेवलपमेंटल इवैल्यूएशन हम कब करें, डीक्यू कितना है उसका, तो हमें डेवलपमेंटल इवैल्यूएशन करना चाहिए. ठीक है, तो सबसे पहले हमको पता होना चाहिए कि डीक्यू हम कैसे कैलकुलेट करते हैं. तो डीक्यू हम कैलकुलेट करते हैं एवरेज एज ऑफ अटेनमेंट ऑफ माइलस्टोन्स, मतलब जो कि आइडियल एज होनी चाहिए. आइडियल एवरेज एज लेते हैं. ठीक है, जो कि नॉर्मल बच्चों में या नॉर्मल बच्चों में होनी चाहिए, पॉपुलेशन नॉर्म्स के हिसाब से एवरेज एज है. वो तो ऊपर आ गया न्यूमरेटर में. डिनोमिनेटर में आएगा ऑब्जर्व्ड एज ऑफ अटेनमेंट ऑफ माइलस्टोन्स. ठीक है, इसे कहते हैं डीक्यू. इसको कर देते हैं हम इनटू 100. अगर हमारा डीक्यू, ठीक है, किसी भी टाइम 70% से कम है, दैट मीन्स ये बच्चा सीवियरली डेवलपमेंटल डिले है, रिक्वायर्स इवैल्यूएशन. तो आपका करेक्ट आंसर आ जाएगा ए, 70%. वो सही ऑप्शन है. इज दैट वेरी क्लियर? ठीक है, ओके, सो लेट अस मूव फॉरवर्ड. नेक्स्ट क्वेश्चन. Which of the following are 5 essential components of the nurturing care? ठीक है, हेल्थ, न्यूट्रिशन, ब्रेस्ट फीडिंग, रिस्पॉन्सिव केयर गिविंग, अर्ली लर्निंग, इम्यूनाइजेशन, सेफ्टी एंड सिक्योरिटी या सप्लीमेंटेशन. करेक्ट पूछा है हमसे आंसर. अब क्वेश्चन आएगा, ये नर्चरिंग केयर किस चिड़िया का नाम है? तो 2018 या 19 में ये WHO ये कॉन्सेप्ट लेके आया था, 5 कंपोनेंट्स होने चाहिए नर्चरिंग केयर की. नर्चरिंग केयर मतलब टेकिंग केयर ऑफ द न्यूबॉर्न राइट फ्रॉम द जेस्टेशनल पीरियड अप टिल 3 years of age. ठीक है, अगर आपने 3 साल तक टॉडलर को सही से संभाला राइट फ्रॉम द इंट्रायूट्राइन पीरियड, तो दिस इज कंसिडर्ड टू बी अ वेरी बिग बून फॉर द डेवलपमेंट ऑफ द चाइल्ड. ठीक है, अब वो 5 कंपोनेंट्स नर्चरिंग केयर के क्या होते हैं देख लेते हैं हम. ठीक है, तो एक तो होता है गुड हेल्थ. ठीक है, गुड हेल्थ होता है. अब गुड हेल्थ का क्या मतलब है? गुड हेल्थ ऑफ द न्यूबॉर्न? नो, गुड हेल्थ ऑफ द न्यूबॉर्न एज वेल एज द केयर गिवर. केयर गिवर इसका मतलब है यहाँ पे हम मदर को रेफर कर रहे हैं, और हमको पता है कि फिजिकल एंड मेंटल हेल्थ ऑफ द केयर गिवर अच्छी होनी चाहिए, तभी वो न्यूबॉर्न को अच्छा केयर या आगे इन्फेंसी में या टॉडलर एज ग्रुप में अच्छा केयर कर पाएगी. सो गुड हेल्थ इन्वॉल्व्स द health and the well-being of both the child as well as the caregiver. Caregiver in this instance we will take it as mother. ठीक है, अब good health of the mother कैसे इंश्योर करोगे? आप माइक्रोन्यूट्रिएंट सप्लीमेंटेशन करते रहो, आप फैमिली प्लानिंग प्रमोट करो. ठीक है, सो दैट शी डज नॉट गेट प्रेग्नेंट रैपिडली, विच विल बी वेरी मच टैक्सिंग फॉर हर हेल्थ. तो वो आपने करना है. अगर बच्चे को, अगर आपको लगता है हाई रिस्क बिहेवियर है, तो HIV टेस्टिंग करो. एंड देन टू प्रिवेंट द मदर टू चाइल्ड ट्रांसमिशन यू स्टार्ट एंटी रेट्रोवायरल्स एट एन अप्रोप्रिएट टाइम एडिक्वेटली. फिर इम्यूनाइजेशन ऑफ बोथ मदर एंड चाइल्ड चलना चाहिए. ग्रोथ मॉनिटरिंग होनी चाहिए बच्चे की. काउंसलिंग होनी चाहिए मदर की, हाउ शी कैन इम्प्रूव द ग्रोथ ऑफ द चाइल्ड. एक्सक्लूसिव ब्रेस्ट फीडिंग प्रमोट होना चाहिए. सो दीज ऑल कॉम्पोनेंट्स कम अंडर द गुड हेल्थ. फिर आता है नेक्स्ट कॉम्पोनेंट इसमें नर्चरिंग में आता है adequate nutrition. Again, adequate nutrition is both of the mother and the child. ठीक है, because why? We know that the nutritional status of the mother has a bearing effect on the development of the child. आपको याद है हमारा ये कॉन्सेप्ट निकल के आया था first 1000 days of life of the child, and 1000 days का मतलब है the intrauterine period as well as the first 2 years of life. They are extremely important, especially for the brain development. We know this 90% of the brain हमारे बच्चे का 2 साल पे डेवलप हो जाता है. So it is very important कि nutrition status of the mother भी intact होना चाहिए, not only the kid. तो हमने वो भी ध्यान रखना है. थर्ड इसमें जो आता है वो आता है सेफ्टी एंड सिक्योरिटी. सेफ्टी एंड सिक्योरिटी का मतलब है प्रोविजन ऑफ या प्रोवाइडिंग सेफ एंड सिक्योर एनवायरनमेंट फॉर द चिल्ड्रन एज वेल एज देयर फैमिलीज. अब सेफ एंड सिक्योर एनवायरनमेंट का मतलब है दैट इज कोई फिजिकल डेंजर नहीं होना चाहिए वहाँ पे, स्ट्रेस फ्री एनवायरनमेंट होना चाहिए. एनवायरमेंटल रिस्क आजकल जो आ रहे हैं जैसे कि पोल्यूशन हो गया, ठीक है, वो सब कम होना चाहिए. एंड द चाइल्ड एंड द केयर टेकर एंड द एंटायर फैमिली शुड हैव एक्सेस टू क्लीन ड्रिंकिंग वाटर एंड हाइजीनिक फूड. ठीक है, तो ये आता है सेफ्टी एंड सिक्योरिटी में, राइट. उसके बाद नेक्स्ट आता है अपॉर्चुनिटीज फॉर अर्ली लर्निंग. इसका क्या मतलब है? इट रेफर्स टू एनी अपॉर्चुनिटी फॉर द बेबी, फॉर द टॉडलर और द चाइल्ड टू इंटरेक्ट विद द पर्सन, प्लेस और ऑब्जेक्ट इन द एनवायरनमेंट. व्हाई? बिकॉज this part of the nurturing, it recognizes the fact that every interaction, चाहे वो positive है या negative है या no interaction है, that is going to have a bearing effect on the development of the child's brain, right, and laying the foundation for later learning. अगर अभी brain की development में problem होगी तो आगे जाके learning disabilities होंगी बच्चे को. तो इसलिए चाहे positive interaction हो, negative हो या no interaction हो, तीनों चीजें they have an effect on the development of the brain. So it is very important that you give a very nurturing, a very kind of interactive environment for the baby to learn, and it should not be just passive learning. ठीक है, तो ये आ गया opportunities for early learning. अब next और the last जो आता है, it actually this is considered to be the मोस्ट इम्पॉर्टेंट फंक्शनल कॉम्पोनेंट, क्योंकि अगर ये कॉम्पोनेंट ठीक है देन ओनली द केयर टेकर्स कैन टेक केयर ऑफ द चाइल्ड इन अ मोर रिस्पॉन्सिव मैनर. ठीक है, तो वो क्या होता है? सो इट रेफर्स टू द एबिलिटी ऑफ द, वी आर कमिंग टू द फिफ्थ कॉम्पोनेंट दैट इज नोन एज रिस्पॉन्सिव केयर गिविंग. एंड रिस्पॉन्सिव केयर गिविंग रेफर्स टू द एबिलिटी ऑफ द केयर टेकर और द पेरेंट, whoever it is, to notice, understand and respond to the child signals in a timely and appropriate manner. ठीक है, so remember that अगर ये सही होगा तभी बच्चे का जो केयर टेकर है बाकी 4 जो कंपोनेंट्स हैं नर्चरिंग के वो उसको फॉलो कर पाएगा. सो दिस इज द मोस्ट इंपॉर्टेंट कंपोनेंट ऑफ द एंटायर नर्चरिंग थिंग विच हैज बीन प्रपोज्ड बाय WHO. ठीक है, तो अब आ जाते हैं इसमें कौन सा आएगा. सो यस, हेल्थ था हमारा, न्यूट्रिशन था हमारा, रिस्पॉन्सिव केयर गिविंग. आई टोल्ड यू दिस इज द वेरी इंपॉर्टेंट फाउंडेशन ऑफ द एंटायर नर्चरिंग केयर. एंड देन अर्ली लर्निंग and then safety and security. तो इसमें options 1, 2, 4, 5 and 7. So which is the correct option over here? Yes, the option A is the correct answer. ठीक है. Then next question करते हैं हम. A full-term baby born with birth weight of 2000 grams comes for well baby visit at 2 months of age. Which of the following nutrition supplements would you advise? Vitamins. So लो बर्थ वेट बेबी जो होते हैं, लो बर्थ वेट बेबी हम यूजली हु कम्स इन दी बर्थ वेट ऑफ 1500 to 2500 ग्राम्स. ठीक है, इन बच्चों को हमने कैसे देखना है. जो लेस देन 1500 ग्राम्स हैं वो तो आपके वेरी लो बर्थ वेट बेबीज हो गए, उनके लिए तो अलग रिकमेंडेशंस होती हैं. पर ये जो 1500 to 2500 ग्राम्स वाले बेबीज होते हैं यूजुअली इनका जेस्टेशन पीरियड मोर देन 32 वीक्स होता है. ठीक है, अब इनमें हम कैसे टैकल करते हैं. रिमेंबर देयर आर 3 थिंग्स टू बी गिवन ओवर हियर. वन इज योर विटामिन डी सप्लीमेंट, अनदर इज आयरन सप्लीमेंट एंड द थर्ड इज जिंक सप्लीमेंट. ये तीनों चीजें हमें देनी पड़ती है. अब विटामिन डी की डोज सबको पता होनी चाहिए. इट इज 400 IU पर डे. ठीक है, एंड दिस हैज टू बी गिवन फॉर एटलीस्ट 1 year एंड आफ्टर 1 year वी चेंज द डोज टू 600 IU पर डे. रिमेंबर, सो ये तो डोज विटामिन डी की हो गई. तो अगर इस हिसाब से देखें तो हमारे दोनों ऑप्शंस गलत है क्योंकि 200 IU पर डे डोज नहीं होती है. ठीक है. What about iron? Yes, iron has to be started. ठीक है, एंड इसकी डोज वही 2 mg per kg per day होती है. एंड यूजुअली वी स्टार्ट आयरन एट अराउंड 4 to 8 weeks ऑफ लाइफ. ठीक है, कहीं पे 4 weeks बोलते हैं, पहले 8 weeks हम बोलते थे. रूल ऑफ 2 होता था, 2 months पे शुरू करो, 2 years तक दो एंड 2 mg per kg per day. ये रूल ऑफ 2 हम प्री टर्म्स के लिए यूज करते थे. बट अब क्या है, अब स्टेटस ये है कि आपको आयरन एज अर्ली एज 4 weeks पे आप चालू कर सकते हो. ठीक है, एंड ये एटलीस्ट 1 year ऑफ एज तक देना है. तो इसमें करेक्ट ऑप्शन क्या हो गया. द डी ऑप्शन इज द करेक्ट ऑप्शन वेयर इट हैज टू बी गिवन अप टिल 1 year ऑफ एज एंड द डोज इज 2 mg per kg per day. ठीक है. ओके, नेक्स्ट क्वेश्चन पे आते हैं. विच आर द फॉलोइंग आर कॉमन प्रॉब्लम्स इन बेबीज विद इंट्रायूट्राइन ग्रोथ रेस्ट्रिक्शन डिलीवर्ड एट टर्म जेस्टेशन. तो ये टर्म IUGR की बात कर रहे हैं. तो इस बच्चे में क्या क्या प्रॉब्लम हो सकती है. हाइपोथर्मिया, हाइपोग्लाइसीमिया, हाइपोकैल्सीमिया तीनों हो सकता है. क्यों होता है हाइपोथर्मिया, क्यों होता है. IUGR बेबी है, इनमें इनएडिक्वेट ब्राउन फैट होता है. ठीक है, दूसरी चीज क्या होती है, इनका लार्ज सरफेस एरिया होता है. सो दे लूज हीट very quickly. ठीक है, so they lose heat very quickly. And moreover, one more thing which contributes to this loss of heat is, apart from large surface area, very thin skin. Even that contributes to the loss of heat from the body. And तीसरी चीज होता है कि इनमें glycogen stores काफी कम होते हैं. Even that is one of the factor responsible for hypothermia. ठीक है. अब हाइपोग्लाइसीमिया पे आ जाते हैं. तो एक तो हमने फैक्टर पहले ही बता दिया आपको कि हाइपोग्लाइसीमिया में एक तो लो ग्लाइकोजन स्टोर्स तो हमने बोले, साथ में इनमें लो फैट स्टोर्स भी होते हैं. क्यों होते हैं, आई डोंट नीड टू टेल यू, बिकॉज ये बच्चे IUGR बच्चे हैं. ठीक है, तो ये दोनों लो होते हैं. अब नेक्स्ट थर्ड ऑप्शन अगर आप देखो, हाइपोकैल्सीमिया क्यों होता है. हाइपोकैल्सीमिया होने के कॉजेज हैं कि इन बच्चों में ट्रांजिएंट हाइपोपैराथायरॉयडिज्म होता है. और इसकी वजह से पैराथॉर्मोन इज वन हार्मोन जिसकी पूरी जिंदगी लगी रहती है कि मैंने सीरम कैल्शियम को गिरने नहीं देना, और अब आपने वो सिस्टम ही बंद कर दिया फॉर ट्रांजिएंट पीरियड. सो दीज चिल्ड्रन हैव अ टेंडेंसी टू गो इनटू हाइपोकैल्सीमिया. मोर ओवर कभी कभी इन बच्चों को IUGR है, पेरेंट्स सोचते हैं, घर वाले सोचते हैं, घर की नानी दादियां सोचती हैं कि चलो बच्चे को जल्दी मोटा करें तो दूध पिलाते हैं. एंड यूजुअली काउज मिल्क अगर पिलाया जाए तो यू शुड नो काउज मिल्क हैज अ वेरी हाई फॉस्फेट लोड एंड दैट इनहिबिट्स कैल्शियम एब्जॉर्प्शन फ्रॉम द इंटेस्टाइन. सो चिल्ड्रन हु आर फेड काउज मिल्क आर ऑल्सो एट रिस्क फॉर डेवलपिंग हाइपोकैल्सीमिया. एंड यूजुअली IUGR बच्चों को कभी कभी स्पेसिफिकली पिलाया जाता है, एंड दैट इज अनदर रीजन व्हाई दे आर प्रोन टू डेवलप हाइपोकैल्सीमिया. राइट। तो ये चीज हो गई हमारी। तो इसमें कौन से ऑप्शंस होंगे 1, 2 एंड 3, तो हमारा करेक्ट आंसर हो गया जी डी ऑप्शन 1, 2 एंड 3, इसमें ऑल 3 प्रॉब्लम्स होती हैं, ठीक है। ओके, नेक्स्ट क्वेश्चन पे चलते हैं। विच वन ऑफ द फॉलोइंग स्टेटमेंट इज करेक्ट रिगार्डिंग अ नॉर्मल न्यूबॉर्न ग्रोथ? वेट लॉस में भी 8 to 10% ऑफ बर्थ वेट इन द इनिशियल 2 weeks ऑफ लाइफ। देख लेते हैं एक बार। Birth weight is regained by 7 to 10 days of age. Birth weight is regained within the first week of life, and weight loss may be 12 to 15% of birth weight in the initial 2 weeks of life. तो इसमें कुछ facts हमें पता होने चाहिए। अगर तो term बच्चा है तो वो lose करेगा 7 to 10%, ठीक है, and by 7 to 10 days तक वो अपना birth weight regain कर लेता है, ठीक है। तो एक तो आपको पता ही होना चाहिए। अगर यही प्री टर्म बच्चा है तो वो लूज करेगा 10 to 15% एंड 42 वीक्स तक आते आते वो अपना बर्थ वेट रिगेन कर लेता है। तो मतलब 2 वीक्स के बाद इसका पॉजिटिव शुरू हो जाता है और इसका यूजुअली अपर लिमिट इज आफ्टर 10 days पॉजिटिव वेट गेन अबव दी बर्थ शुरू हो जाता है, ठीक है। तो ये तो फैक्ट्स हैं। अगर इसके हिसाब से देखा जाए तो हमारा एक ही ऑप्शन बिल्कुल करेक्ट बनता है, एंड दैट इज द बर्थ वेट इज रिगेन्ड बाय 7 to 10 days ऑफ एज। फर्स्ट क्यों गलत है? वेट लॉस में भी 8 to 10% इन द इनिशियल 2 weeks ऑफ लाइफ, कुछ बोला नहीं है इन्होंने, तो हम टर्म ही सोचेंगे, तो ये गलत हो गया, क्योंकि 7 to 10% या 8 to 10% लो तो आप 10 days तक लो, 2 weeks तक मत लो। बर्थ वेट इज रिगेन्ड विद इन द फर्स्ट वीक ऑफ लाइफ, नहीं वो भी नहीं होता, 7 to 10 days होता है। वेट लॉस में भी 12 to 15% initial, they have not mentioned as of preterm. So if they have not mentioned, then we have to consider this statement they are trying to apply to a term infant, which is again a wrong statement. तो हमारा करेक्ट आंसर यहाँ पे क्या हो गया? हमारा करेक्ट आंसर हो गया बी ऑप्शन, ठीक है, क्लियर। ओके, देन नेक्स्ट क्वेश्चन करते हैं। विच ऑफ द फॉलोइंग abnormalities occur from vitamin D deficiency in children? Craniotabes, bossing of frontal and parietal bones, muscle hypotonia, या shrinking of epiphysis at the lower end of radius। तो किसकी बात कर रहे हैं? सीधा सीधा हमको पता पड़ रहा है जी, ये लोग बात कर रहे हैं रिकेट्स की, ठीक है। वी नो द कॉमनेस्ट कॉज ऑफ रिकेट्स इन आवर कंट्री इज नॉट कैल्शियम डेफिशिएंसी, इट इज विटामिन डी डेफिशिएंसी, राइट। सो क्रेनियोटेबीज होता है, बिल्कुल जी, थिनिंग ऑफ द आउटर स्कल, आउटर टेबल ऑफ द स्कल होता है, दैट इज क्रेनियोटेबीज, हमको पता है। देन फ्रंटल बॉसिंग होती है, ठीक है, ये भी ठीक है, एंड इवन द पैराइटल बोन्स दे बिकम, ठीक है, वेरी प्रोमिनेंट। मसल हाइपोटोनिया भी होता है, हमको पता है। फोर्थ ऑप्शन देखते हैं, श्रिंकिंग ऑफ एपिफिस एट द लोअर एंड ऑफ द रेडियस। ऐसा कुछ भी नहीं होता। इफ यू नो कि एक्चुअली जो ग्रोथ प्लेट होती है, all the changes of rickets, they occur at metaphysis, and the growth plate, which is initially made up of cartilage, and there is a programming in that cartilage that the chondrocyte should undergo apoptosis, ठीक है, and this is because of the presence of the phosphate होना चाहिए। तो chondrocytes which are laying down the cartilage, they should undergo apoptosis, और जैसे ही उनका apoptosis होगा तो mineralization हो जाता है cartilage का, और हमारा ends of the long bones, that is epiphysis, बनने लग जाती है, right? ये तो नॉर्मल मैकेनिज्म होता है। अब श्रिंकिंग ऑफ, अगर रिकेट्स हो गई, दैट मीन्स विटामिन डी की डेफिशिएंसी है, तो फॉस्फेट भी लो होगा एंड कैल्शियम भी लो होगा। फॉस्फेट क्यों लो होगा? क्योंकि विटामिन डी डेफिशिएंसी के कारण कैल्शियम लो है, क्योंकि विटामिन डी डेफिशिएंसी कैल्शियम के लिए रिक्शा का काम करता है, राइट। हर जगह वो ही ले जाता है। इंटेस्टाइन से विटामिन डी डेफिशिएंसी, विटामिन डी एब्जॉर्ब करता है कैल्शियम को, किडनी से विटामिन डी करता है एब्जॉर्ब, एंड अगर तब भी काम न बने तो वो बोन से ले आता है कैल्शियम को, राइट। तो कैल्शियम की कमी हो जाती है क्योंकि विटामिन डी डेफिशिएंसी है। कैल्शियम की कमी को कौन सेंस करता है? पीटीएच सेंस करता है। पीटीएच इंक्रीज हो जाता है, एंड इंक्रीज पीटीएच का मतलब है इंक्रीज फॉस्फेट लॉस इन द यूरिन। तो फॉस्फोरस की कमी के कारण एपोप्टोसिस नहीं होता, तो वहां पे कॉन्ड्रोसाइट्स हाइपरट्रॉफी होते जाते हैं, एंड दैट इज व्हाई मोर एंड मोर अनऑसिफाइड कार्टिलेज इज बीइंग डिपॉजिटेड, एंड दैट लीड्स टू द ends of the long bones becoming splayed, frayed and cupped। क्या होता है स्प्रेइंग, फ्लेइंग और कपिंग की? तो इसलिए आप देखो एंड्स ऑफ द लॉन्ग बोन्स ये ऐसे वाइडेंड हो जाते हैं, ना कि श्रिंकेज, ठीक है। कपिंग भी हो जाती है, इतनी बढ़िया कपिंग दिखा रखी है यहाँ पे, एंड द मेटाफिजियल बॉर्डर इट बिकम्स वेरी रैगेड टाइप्स, ठीक है। तो ये चेंजेस होते हैं, ना कि श्रिंकेज ऑफ एपिफिसिस। तो हमारा करेक्ट आंसर क्या होगा? 1, 2 and 3, एंड दैट इज योर ऑप्शन ए, राइट। तो ये हो गया। नेक्स्ट करते हैं, विच ऑफ द फॉलोइंग करेक्टली डिस्क्राइब्स द मोड ऑफ इनहेरिटेंस। अगेन अ वेरी वेरी हलवा क्वेश्चन, वी शुड नो, ये तो आपको रट के घोट के पी जाओ। इट इज एक्स लिंक रिसेसिव होता है हीमोफीलिया, चाहे हम हीमोफीलिया ए की बात करें चाहे हम हीमोफीलिया बी की बात करें। हमें पता है ए होता है 8th फैक्टर डेफिशिएंसी की वजह से, एंड हीमोफीलिया बी होता है जिसे क्रिश्चियंस डिजीज भी कहते हैं 9th फैक्टर 9 की डेफिशिएंसी की वजह से, एंड बोथ आर एक्स लिंक रिसेसिव। ठीक है, तो ये हमारा क्वेश्चन है, डी ऑप्शन करेक्ट होगा। ठीक है, ओके नेक्स्ट करते हैं, विच ऑफ द फॉलोइंग इज एसोसिएटेड विद लो एमसीवी ऑफ रेड ब्लड सेल्स। तो अगर आपको पता हो एनीमिया का क्लासिफिकेशन शुरू ही एमसीवी से होता है। ठीक है, एमसीवी देखते हैं, देन देखते हैं कि जी लो कौन सा है, नॉर्मोसिटिक कौन सा है और मैक्रोसिटिक कौन सा है। ठीक है, तो हाउ डू वी क्लासिफाई मैक्रोसिटिक, नॉर्मोसिटिक एंड माइक्रोसिटिक। ठीक है, माइक्रोसिटिक कहते हैं लेस देन 80 फेम्टोलीटर, उसको कहते हैं हम माइक्रोसिटिक, दैट इज लेस देन 80 फेम्टोलीटर पर सेल। दिस जो नॉर्मोसिटिक होता है वो होता है 80 to 100 फेम्टोलीटर। ठीक है, वॉल्यूम, ठीक है, ऑफ अ सेल, एंड मैक्रोसिटिक होता है मोर देन 100 फेम्टोलीटर। राइट, तो इसमें हमें लो एमसीवी में तो हमें 4 चीजें रटी हुई होनी चाहिए। कौन कौन सी? एक होता है आयरन डेफिशिएंसी एनीमिया, दूसरा होता है थैलेसीमिया, ठीक है, और तीसरा होता है सिड्रोब्लास्टिक एनीमिया, और चौथा होता है अनीमिया ऑफ क्रॉनिक डिजीज। राइट, ये हमको याद करवाया जाता है राइट फ्रॉम द फर्स्ट प्रॉफ। राइट, तो ऐसे में जब लो एमसीवी पूछा हुआ है तो हमें एटलीस्ट ये 4 तो चीजें याद होनी चाहिए, और हमको ये भी याद होना चाहिए कि फोलेट डेफिशिएंसी एंड विटामिन B12 डेफिशिएंसी से मैक्रोसिटिक होता है। ठीक है, जो नॉर्मोसिटिक होता है दैट इज अगेन डिवाइडेड इनटू विद नॉर्मल रेटी काउंट और विद इंक्रीज्ड रेटी काउंट। इंक्रीज्ड रेटी काउंट में you don't need to be so much worked about, क्योंकि इंक्रीज रेटी काउंट वाले वो सारे डिसऑर्डर्स आएंगे जिसमें बच्चे को हेमोलिसिस हो रहा है, जैसे कि हेरिडिटरी स्फेरोसाइटोसिस, जैसे कि सिकल सेल एनीमिया, जैसे कि पायरुवेट काइनेज डेफिशिएंसी। ठीक है, इन सब में आपके बच्चे को नॉर्मोसिटिक आरबीसीज बट विद हाई रेटी काउंट, ये सारी चीजें आती है। ऑटोइम्यून हेमोलिटिक एनीमिया या PNH, पैरोक्सिस्मल नॉक्टर्नल हीमोग्लोबिनुरिया। ठीक है, तो ये सारी चीजें आती हैं इंक्रीज रेटी काउंट में, प्लीज रिमेंबर। तो ऐसे में अगर आप देखो तो ये तो नॉर्मोसिटिक हो गया। ठीक है, फोलेट डेफिशिएंसी एंड ये तो मैक्रोसिटिक हो गया। तो हमारा करेक्ट आंसर, लो एमसीवी पूछा था हमसे, तो हमारा करेक्ट आंसर हो गया थैलेसीमिया हो गई। ठीक है, ओके नेक्स्ट करते हैं क्वेश्चन। नेक्स्ट क्वेश्चन इज विच वन ऑफ द फॉलोइंग इज एन एग्जांपल ऑफ हाइपोगोनाडोट्रोपिक हाइपोगोनाडिज्म। इफ यू लुक एट द लिस्ट, एक बहुत इंपॉर्टेंट इसमें यहाँ पे जो आपको नींद में भी पता होना चाहिए, एंड दैट इज कैलमन सिंड्रोम। एंड नॉट ओनली दिस, योर नेक्स्ट क्वेश्चन इज ऑल्सो रिलेटेड। कैलमन सिंड्रोम के बारे में आपको 2-3 चीजें पता होनी चाहिए। क्या? एक तो हाइपोगोनाडोट्रोपिक हाइपोगोनाडिज्म है, दैट मीन्स देयर विल बी डिलेड प्यूबर्टी बिकॉज गोनाडोट्रोपिक हार्मोन्स दे आर नॉट सीक्रेटेड इन एडिक्वेट अमाउंट्स, प्लस साथ में वेरी इंपॉर्टेंट is the presence of anosmia. Anosmia is the decreased smell. तो आपका जो next question है वो भी similar ही है, that GnRH deficiency, that is your with hyposmia is typically seen in, again the option over here, the correct option will be Kalman syndrome. So there's an impaired sense of smell in Kalman syndrome with hypogonadotropic hypogonadism, and because of which what happens, जो males होते हैं उसमें आपकी micro penis होती है, and तुम्हारे आपके जो delay of secondary sexual characters, that means जो वॉइस चेंज होनी चाहिए या डेवलपमेंट ऑफ प्यूबिक एक्सिलरी हेयर होना चाहिए, वो सब प्रॉब्लम्स होती है इन बच्चों में। अगर फीमेल्स हैं तो फीमेल्स में मेंस्ट्रुअल साइकिल मतलब मिनार्के का सही टाइम पे शुरुआत नहीं होगी, एंड सेकेंडरी सेक्सुअल कैरेक्टर्स जैसे कि ब्रेस्ट डेवलपमेंट एंड वो सब भी डिलेड रहेगा। ठीक है, सो दिस इज इट। एंड अलॉन्ग विद इट, अगर बच्चे को इम्पेयर्ड सेंस ऑफ स्मेल है तो आपने सबसे पहले क्या सोचना है? कैल्मन सिंड्रोम सोचना है। समझ गए आप? ओके, so this is Kalman, and this is hypogonadotropic hypogonadism is also Kalman syndrome. ठीक है, next is a 14-year-old boy comes up with the chronic diarrhea and malnutrition. The physician suspected celiac disease. Which of the following are correct in this diagnostic workup? So celiac सोचा है तो presence of IgA anti-endomysial antibody, yes ये सही है. Absence of reduced height of villi on intestinal बायोप्सी, आई फाइंड दिस ऑप्शन अ बिट दिस थिंग, रिड्यूस्ड हाइट तो होती है पर उसका एब्सेंस, तो इसका मतलब ये तो मुश्किल लग रहा है, ठीक है। देन इंक्रीज लिम्फोसाइट्स इन लैमिना प्रोपिया इन द स्मॉल इंटेस्टाइनल बायोप्सी, या एंड ये भी सही है बिल्कुल, एंड एब्सेंस ऑफ टीटीजी एंटीबॉडी इन द सीरम, ये गड़बड़ लग रही है, तो टीटीजी एंटीबॉडी तो होना चाहिए, राइट। तो अगर देखा जाए तो 1 और 3 तो सही लग रहे हैं, पर 1 और 3 तो सब सिर्फ 1 और 3 तो नहीं, तो आई थिंक सेकंड ऑप्शन को हम सही कर लेते हैं। से रिड्यूस्ड हाइट ऑफ विलाई ऑन, ये होना चाहिए, रिड्यूस्ड हाइट ऑफ विलाई ऑन इंटेस्टाइनल बायोप्सी। अगर हम ऐसा देखें तो हमारा 1, 2 एंड 3 तीनों सही चल रहे हैं, तो 1, 2 एंड 3 ऑप्शन करेक्ट आता है इसमें, ठीक है। रिमेंबर टीटीजी एंटीबॉडी एब्सेंट तो नहीं होता है, यूजुअली 91 to 100% सेंसिटिव एंड 92 to 100% स्पेसिफिक होता है टीटीजी, तो इतने आराम से एब्सेंट तो नहीं रहेगा ये एंटीबॉडी इन द सीरम। सो दैट इज व्हाई इफ दिस इज अ करेक्ट दिस थिंग, रिमेंबर, ठीक है, ये करेक्ट तभी होगा जब हम एब्सेंस ऑफ को काट करके रिड्यूस्ड हाइट ऑफ विलाई ऑन इंटेस्टाइनल बायोप्सी लिखें। तो इफ वी हैव टू डिस्कस हाउ डू वी मेक द डायग्नोसिस ऑफ सीलिएक डिजीज, तो 3 चीजें होती हैं जिसपे डायग्नोसिस बनता है, ठीक है। एक होती है सिरोलॉजी, सिरोलॉजी में आपको पता है क्या क्या आता है। सिरोलॉजी में हम IgA बेस्ड टीटीजी एंटीबॉडी देखते हैं, एंटीबॉडी अगेंस्ट द टिश्यू ट्रांसग्लूटामिनेज, एंड एंटी एंडोमीसियल एंटीबॉडी देखते हैं। रिमेंबर टीटीजी टेस्ट करना काफी आसान होता है, EMA टेस्ट करना थोड़ा डिफिकल्ट होता है, ठीक है, बट ये दोनों एंटीबॉडीज काफी स्पेसिफिक, अराउंड 90 to 100% स्पेसिफिक एंड सेंसिटिव होती हैं। सो ये तो सिरोलॉजी की बात हो गई। एंड इसके साथ वेरी इंपॉर्टेंटली अगर ये नेगेटिव आता है तो आपको IgA लेवल जरूर देखना चाहिए, कि कभी कभी इन बच्चों में, सीलिएक डिजीज के बच्चों में वैसे ही IgA लेवल्स लो होंगे, तो वो एंटीबॉडीज कैसे बनाएंगे फॉर अगेंस्ट टीटीजी एंड EMA। तो ये तीनों चीजें आपने देखनी होती है। अगर सेकंड वे ऑफ मेकिंग अ डायग्नोसिस, कॉम्प्लीमेंटिंग द डायग्नोसिस इज थ्रू अपर GI एंडोस्कोपी। अपर GI एंडोस्कोपी में क्या देखने को मिलता है, एब्सेंस ऑफ फोल्ड्स, ठीक है, एब्सेंस ऑफ फोल्ड्स या स्कैलॉप्ड फोल्ड्स अगर आपको दिखें, और कहाँ आप लेते हो, कहाँ से बायोप्सी लेते हो, ठीक है, आप लेते हो सेकंड या थर्ड पार्ट ऑफ डुओडेनम से बायोप्सी लेते हो, मल्टीपल बायोप्सीज लेनी चाहिए, एंड देन दैट इज सब्जेक्टेड टू माइक्रोस्कोपिक एग्जामिनेशन, तो उसमें ये प्रॉब्लम देखने को मिलती है, ठीक है। तीसरा तरीका ऑफ मेकिंग अ डायग्नोसिस इज ऑब्वियसली डूइंग द प्रॉपर स्टेनिंग एंड हिस्टोलॉजी। तो उसमें आपको क्या क्या देखने को मिलता है, इंक्रीज इन इंट्रा एपिथेलियल लिम्फोसाइट्स, ठीक है, कितने, मोर देन 30 per 100 एंट्रोसाइट्स, तो इंक्रीज इन intraepithelial lymphocytes। अब कभी कभी इसको हम साथ में ये भी बोल देंगे, इंक्रीज इन्फिल्ट्रेशन ऑफ प्लाज्मा सेल्स और लिम्फोसाइट्स इनटू द लैमिना प्रोप्रिया, ठीक है, ये होता है। फिर सेकंड चीज और हिस्टोलॉजी में क्या देखने को मिलती है, इंक्रीज ग्रिप लेंथ देखने को मिलती है, पार्शियल टू टोटल विलस एट्रोफी देखने को मिलती है, डिक्रीज विलस टू क्रिप्ट रेशियो देखने को मिलता है, ठीक है। सो क्योंकि विलस एट्रोफी देखने को मिलती है, तो रिड्यूस्ड हाइट ऑफ विलाई ऑन इंटेस्टाइनल बायोप्सी मेक्स मोर सेंस इफ वी हैव टू take at least 3 correct options from here, right? तो ये चीज देखने को मिलती है। अब इसमें आपको पता होना चाहिए, जो एस्पागान है हमारी, एस्पागान क्या है, यूरोपियन सोसाइटी ऑफ पीडियाट्रिक गैस्ट्रोएंट्रोलॉजी, हेपेटोलॉजी एंड न्यूट्रिशन। सो दिस हैज कम अप विद a kind of relief कि diagnosis is possible in the absence of duodenal biopsy अगर सीलिएक डिजीज के बच्चों में ये 3 चीजें हो। अब वो क्या 3 चीजें जिसमें कि हम बायोप्सी अवॉइड कर सकते हैं, तो यहाँ तो सबसे पहली बात, इनका HLA DQ8 एंड DQ2 पॉजिटिव हो, ठीक है, साथ में इनका जो TTG है, ठीक है, उसकी लेवल क्वांटिटेटिवली 10 times अपर लिमिट ऑफ नॉर्मल हो, ठीक है, और तीसरा IgA एंटी एंडोमीसियल एंटीबॉडी भी पॉजिटिव हो। अगर ये 3 चीजें हैं बच्चे में along with the clinical symptoms, then you can avoid a duodenal biopsy एंड मेक अ डायग्नोसिस ऑफ सीलियाक डिजीज। ठीक है, तो ये कुछ कंफर्ट लेके आइए, बट एनीवेज लेट मी टेल यू, एंटी एंडोमीजियल एंटीबॉडी करना is just not available everywhere, so therefore we actually fall back on duodenal biopsy. ठीक है, so how do you make a diagnosis of celiac disease? Apart from that is clinical features compatible होने चाहिए, positive intestinal biopsy आनी चाहिए जब आपने biopsy करी, with or without serology. With serology वो बहुत अच्छी बात है, अगर serology negative आ रही है but clinical features हैं, then you should go for intestinal biopsy. And very importantly, the third is unequivocal response to gluten free diet within 12 weeks of starting gluten free diet. अगर within 12 weeks आपका बच्चा improve हो गया, anemia disappear हो गया, chronic diarrhea disappear हो गया, that is a sure short way कि बच्चा GFD मतलब gluten free diet पे improve हो रहा है, that means ये बच्चे को celiac है। celiac क्या होता है? Sensitivity to the gliadin component of the wheat, where the child does not tolerate it well and hence autoimmune attack होता है उसके enterocytes पे and hence lands up with malabsorption, right? So this is all about all the questions that we have discussed today. Keep MCQing. All the best for your exams, and I hope this discussion benefits you tremendously. Thank you.